Sure.
Okay. I'll give you the thumbs up when it's time.
Okay. Well, hello, everyone. Good morning, good afternoon, good evening, wherever you are all over the world. It is an honor and a pleasure for me, on behalf of the Heart Institute leadership, to welcome everyone to this 4th annual UPMC Children's Hospital, the Silva Center and Ebstein's Anomaly Symposium today. As you know, last year we celebrated the 30th anniversary of the COUNT procedure, and this has been a wonderful experience, and we want to share with you some of the updates and knowledge that we have on this very challenging disease. So in this opportunity today, we are very honored to have some guests, including Dr. Craig Knott from Dr. Knott Craig from yes, from yes, from Le Bonheur. And also we have Dr. Norman Silverman, as you know, and also we have a guest from Brazil, an experienced imager, Dr. Simone Pedra. So it is a pleasure to welcome you all, and we'll be sharing with you some of the knowledge and some updates. To start, we are going to go on with the fetal echocardiography to begin with, and we have among our faculty Dr. Jackie Weinberg. Jackie Weinberg is Assistant Professor of Pediatrics here at the University of Pittsburgh, and she directs our fetal echocardiography program. So welcome, Jackie, and we'll get going without further ado.
Good morning, everybody. I'm excited to get us started this morning. So we'll talk a little bit this morning about the prenatal diagnosis of Ebstein's anomaly. So when we look at the rates of detection of Ebstein's, there's a high rate of prenatal diagnosis for severe cases, those that require intervention early in life, due to the ability to detect the lesion on the 4-chamber view. So we can see with the red stars there that there is a high rate of diagnosis. And that's because, as we see in this normal 4-chamber view, it is, as we'll see with our Ebstein's cases, it is readily detectable on this 4-chamber view, which has long been standard on OB screening ultrasounds. When we look here, the heart is supposed to be less than a third of the area of the fetal chest, and the circumference should be less than half of that of the chest circumference. Again, we can see that the there are 4 good-sized chambers here in this normal heart, with the right ventricle and the left ventricular dimensions approximately equal at mid-gestation, and the right atrial and left atrial size approximately equal as well. We'll contrast that with some cases of Ebstein's anomaly. So in this first case, this was a referral to us at 21 weeks gestation due to an abnormal screening ultrasound, obstetric ultrasound. And as we see here, so again, I've oriented you on a lot of the images today for those that aren't as comfortable with fetal echo, but spine posteriorly, and this is anterior, right, and left on the fetal chest. And as we can see here, the heart takes up a larger proportion than normal of the fetal chest. And there's right atrial enlargement most obviously here. The right ventricle is also dilated as compared to the left atrial and ventricular size. We can see here is the tricuspid valve, and there is significant tethering and apical displacement of the septal leaflet seen there. And when we look with color, we can see a significant amount of tricuspid valve insufficiency with that blue jet there. This fetus was followed, and at 25 weeks gestation, there was progression of the degree of cardiomegaly. Again, you see the significant right atrial and right ventricular enlargement, and with color, ongoing tricuspid insufficiency. This fetus was initially felt to have pulmonary valve leaflets that did have motion consistent with some antegrade pulmonary flow at that 21-week ultrasound. However, by 25 weeks gestation, there was no longer forward pulmonary valve flow and reversal of flow in the ductal arch. At 34 weeks gestation, again, we can see further progression of that cardiomegaly with that heart stretching from the left to the right wall of the fetal chest. In the center view, we have a short axis, again, showing the discrepancy between the left ventricular size and that right ventricular size, right atrium as well. And on the right, although the pulmonary valve was not well seen on this last fetal echo, you can see reversal of flow in the ductal arch there with that blue jet. We also do see tricuspid valve dysplasia in the fetus with overall fairly similar outcomes, but this is to contrast that last case of Ebstein's that did have apical displacement of the septal leaflet. In this case, we again see cardiomegaly with a very significant amount of right atrial and right ventricular dilation. However, the tricuspid valve septal leaflet is in a normal position. You can appreciate that the tricuspid valve leaflets are thickened and don't co-opt well. And although you can't see in the right the leaflets themselves, you can appreciate the degree of tricuspid valve insufficiency in this case with a very wide jet. This same fetus also had developed functional pulmonary valve atresia. The pulmonary valve is here, and there's no obvious forward flow or insufficiency, and there was reversal of flow in the ductal arch. In this case that was referred to us late in gestation, this fetus was at 36 weeks gestation, and again, you can see cardiomegaly, and we can see very nice pictures of that tricuspid valve. In this case, there was only mild apical displacement of that septal leaflet, but you can appreciate significant tethering, and the anterior leaflet seen there also had a significant amount of tethering to the free wall of the right ventricle. Similarly, there was a significant amount of tricuspid insufficiency and functional pulmonary atresia. Here you can see this tiny red jet here represents a small jet of pulmonary valve insufficiency, and we'll talk more about the implications of that. In this case, the pulmonary insufficiency remained trivial through the remainder of the pregnancy. We do try and take a careful look at those tricuspid valve leaflets from multiple views. So this is a short axis down here. We can see part of the septal leaflet of the tricuspid valve here, the inferior leaflet, and the anterior leaflet, again in this case, which had attachments to the anterior wall of the right ventricle. In this case, at 37 weeks gestation, this was an unusual case where the septal leaflet of the tricuspid valve was clearly displaced apically, and if you can appreciate from this view here, the mitral valve hinge point is approximately here. The septal valve hinge point is apically displaced, but also appeared to have a flail portion of the leaflet. It's also seen in this view on the right, where there's very abnormal motion of that tricuspid valve septal leaflet and resultant severe insufficiency. And this patient was referred at 33 weeks gestation. You can see that in this case, there's more significant apical displacement of the tricuspid valve septal leaflet and very thick, prominent attachments of the anterior leaflet to the free wall of the right ventricle. You can also see in this case, again, severe cardiomegaly and also the development of a pericardial effusion. In the center, in the same case, we can see some attachments of that anterior leaflet to the anterior wall of the right ventricle, severe TR, and retrograde flow in the ductal arch with a jet of pulmonary insufficiency entering the right ventricle. In yet another case, this was a case referred at 34 weeks gestation, and this was felt to be a very severe amount of apical displacement of the tricuspid valve leaflets, so much so that very little tricuspid valve tissue could be identified. It was felt to we also considered the diagnosis of an unguarded tricuspid valve in this case. As you can see from the color image, it's difficult to appreciate where the tricuspid valve coaps, but you can clearly see that there's two-fro flow across where the tricuspid valve annulus would be. This baby also had a retrograde flow in the ductal arch consistent with functional pulmonary atresia. In another case that was referred to us at 34 weeks gestation, we can see on the left that the septal leaflet is actually very apically displaced, but as we sweep up, we can see portions of the inferior and anterior tricuspid valve leaflets. And again, we see swirling in that atrialized portion of the right ventricle consistent with significant tricuspid insufficiency. This baby, unfortunately, at 34 weeks gestation, had also developed pulmonary insufficiency. So this is posterior and anterior on the chest. Looking at the pulmonary valve, there's no obvious forward flow going across the pulmonary valve, and the blue jet represents insufficiency. By Doppler, the pulmonary insufficiency was continuous throughout the cardiac cycle. But fortunately, at that point, this baby had a normal umbilical artery Doppler, thus had not progressed yet to a true circular shunt. In this case that was referred to us late in gestation, these are actually images from the OB ultrasound at 28 weeks gestation. At this point, there is cardiomegaly, not quite as significant as some of the other cases we've seen. The tricuspid valve leaflets are difficult to appreciate. You can see where the tricuspid valve annulus would be, but the actual leaflets are difficult to see. However, with color, you can see two-fro flow across that tricuspid valve annulus. At that same time, there was felt to be a lack of forward flow across the pulmonary valve, and the red jet represents pulmonary insufficiency entering the right ventricle. As you can see in this still frame on the right, there was retrograde flow in the ductal arch, and also at that time, there was a normal umbilical artery Doppler. However, the same fetus was seen at 34 weeks gestation here in our clinic. In this view on the left, you can appreciate cardiomegaly. The right ventricle is dilated, as well as significant right atrial enlargement. We can see that the septal leaflet is apically displaced. The anterior leaflet is more mobile. And also seen here, there were, however, attachments were initially in the inferior leaflet, and then you see portions of the anterior leaflet. There are some attachments to the right ventricular free wall. This baby had functional pulmonary atresia as well. We can see the pulmonary artery here. The pulmonary valve leaflets do not appear to move normally. We can again see some of those attachments of the tricuspid valve leaflets. And with color, there was a significant amount of pulmonary insufficiency, which had increased from the prior OB study. The red jet here represents retrograde flow in the ductal arch. This was also continuous pulmonary insufficiency by Doppler. And unfortunately, this baby had developed abnormal umbilical artery Dopplers at this point with a cessation or even reversal of flow at end diastole. So putting together all these cases, I've shown a variety of the degree of tricuspid valve disease, but when we think about severity, that part of it always doesn't correlate well with the severity or the risk of mortality. So the things that we do look for are the degree of cardiomegaly by the area and circumference ratios to the fetal chest. We look at the degree of right atrial and right ventricular enlargement, the severity of the tricuspid valve insufficiency and the velocity, as well as the development of pulmonary insufficiency. Of the larger studies that have looked at predictors of both in utero mortality and postnatal or early postnatal mortality, the predictors do include in various studies cardiomegaly and larger tricuspid valve annulus score, the severity of the TR and the gradient, as I mentioned, as a measure of how much force the right ventricle is still able to generate, a lack of antegrade pulmonary blood flow and retrograde ductal flow, the development of pulmonary insufficiency, and especially when that develops early in gestation, the right-left ventricular ratio as an assessment of the degree of right ventricular dilation. In some of the newer studies have looked at the MPI of the left ventricle as far as an assessment of fetal left ventricular function as a predictor of outcome, earlier gestational age at diagnosis, and presence of a pericardial effusion. When we do have cases where a circular shunt has become evident, there is some early and encouraging research looking at the use of NSAIDs in treatment of the mother in order to treat a circular shunt. And the use of NSAIDs allows constriction of the ductal arch in the fetus with an attempt to decrease the amount of pulmonary insufficiency and improve those arterial Dopplers in the fetus. And in this, one of the larger studies looking at this from multiple centers, they showed that they were able to achieve significantly higher gestational age at delivery of the babies, in which they were able to achieve ductal constriction and a greater chance of live birth. So very encouraging. The numbers are still small as far as the babies that have been treated, but it does show some promise. So thank you guys very much for having me speak today. And I think Dr. Kreutzer will be up to introduce the next speaker. Thank you.
Thank you, Jackie, that was fantastic. And now our next presenter is Dr. Norman Silverman, who, as you know, is Professor of Pediatrics and Honorary Faculty Emeritus of Pediatrics at Stanford University. Has had incredible contributions throughout his life in the area of imaging, and especially Ebstein's anomaly is he has a passion for this disease. And he'll be talking about echocardiogram insights on Ebstein's anomaly. Dr. Silverman.
Thank you, Jackie. Let's see whether this is working. Good morning. Is there a microphone? This is it. Thank you very much for having me here this morning. I just need to make sure that I get this in play mode. I really am very grateful to the organizers of this symposium for inviting me to address you. And I figured that I would look at this session from the point of view of what does an echocardiographer do when he looks at a patient for the surgical procedure that the Silvas have pioneered. So let's just have a look at what Ebstein's malformation really is. On the left-hand side, you can see a beautifully normal tricuspid valve with the right ventricular body removed. You see the anterior papillary muscle, APM, the septomarginal trabeculation, the parietal band of the crystal ventricular infundibular folds, and you see the attachment of the median and anterior papillary muscle, subtending both the septal and the anterior leaflet. When we look at an Ebstein's and we look at this from the right ventricular apex in the same way as we looked at it in the normal, you can see the variability of the Ebstein's valves related to what you see with the echocardiogram. And in fact, there's fusion between the anterior leaflet and the septal leaflet, as you can see, and a so-called keyhole orifice that we see here. My mouse seems not to be working. So that's what an Ebstein's malformation looks like from the ventricular aspect, an aspect that is not often seen by the surgeons who operate through the atrium. This is a patient of mine, the first patient on the left-hand side, who by the physiologist deemed that this right to left shunt could be managed by closing the atrial septal defect, whereupon within an hour of this closure, the patient succumbed and died. And so we have his heart. And what this looks is the surgical view of the tricuspid valve. And you can see the tricuspid AV junction here. It's not an annulus. And you can see this progressive displacement of the septal leaflet, which is done in green, going down to the junction between the septal and inferior leaflet, which also appear to have fusion on them. And this stays that way until we get down to the anterior leaflet, which is normally placed. On the center area is a picture of how an echocardiogram would be done on the right, and shows the positions of the right atrium, the atrioventricular junction, and the atrialized and functional parts of the right ventricle. And Dr. Christian Schreiber, in looking at 27 of these defects, put in the position of the atrioventricular junction and annulus and valve in these positions. So we can see that there's progressive displacement around this hinge point of the tricuspid annulus. And here on the right is an echocardiogram in a subcostal coronal cut, which shows a number of these features. First of all, there's pulmonary insufficiency, part of a circular shunt. The tricuspid valve jet originates within the right ventricular outflow tract. Here is the true atrioventricular junction. And here we can see from this the perpendicular shunt coming down towards the diaphragm here, an unusual position for tricuspid regurgitation. And this indicates where the atrioventricular true valve junction is situated. Let's just go back a little bit and look at the embryology of what happens. On the left-hand side, at 8 weeks of gestation from the Carnegie collection of embryos is a section of a normal tricuspid valve. And at the end of the embryonic period, the valve shows only an anterior and septal leaflet. And as you can see, there is no delamination of this valve from the septum. And this is what happens in Ebstein's malformation, because as the delamination occurs, the valve is freed and is situated in its normal position to the annulus later on in gestation. On the center is a new way of looking at this from a paper by Hicksboers and Lammers and Anderson, showing reconstruction of the various parts of the heart in various findings. And you can see here at the end of the 8th week that there is really only a bicuspid tricuspid valve. The inferior leaflet has not yet developed. And on the right here is an echocardiogram at 19 weeks of gestational age. And you can see already the typical features of Ebstein's, the displacement of the septal leaflet of the tricuspid valve, the presence of tricuspid insufficiency, and an increase in the right atrium. And I think that we have to be cognizant of what the physiology is at this time in life. Because in the fetus at this time, the blood pressure, the systemic blood pressure, is about 10 to 15 millimeters of mercury. And during the course of development, the pressure in the systemic vessels and the pulmonary artery increases from 10 to 15 all the way up until 60 and 70 millimeters of mercury, placing a burden on the tricuspid valve during delivery. during gestation. Now, the previous speaker demonstrated this condition of the atrialized right ventricle and right atrium as part of the heart, and when this appreciated to a level of greater than 1:1 for the rest of the heart, the prognosis of the Ebsteins appeared to be impaired. And this was the origin of this paper that I wrote in 1988, 1989, it got published, of this prognostic thing that became the Sellermeyer index. And being such a small world, Dr. Sellermeyer's family is part of my family in Australia, so wheels within wheels. And here is a specimen where we've put that same atrialized right ventricle, right atrium. I'll use this example again and again, and I'll take the labels away so that you can see all of these things. And then 3 examples of Ebstein's malformation during fetal development. And you can see here the tricuspid valve is herniating, septal leaflet, and in this example as well, that the septal leaflet is malformed and rotated, and the anterior leaflet is large and say-like, and this is a progression from mild to moderate to severe Ebstein's malformation. In this patient, the valve has been rotated so far forward that it's actually not visible, and this is all atrialized right ventricle. And tremendous increase in the bulge of septum primum into the right atrium. Now, the physiological feature of these patients that's important that I've alluded to is the development of tricuspid regurgitation. It can be mild, it can be severe, and it can be non-existent when the valve is entirely fused. So the variability to the Ebsteins from not only the displacement, but the valve may not delaminate at all and remain with a position of similar to tricuspid atresia. And we previously have heard of this circular shunt, which my fellows have called the circle of death. And here is that same 19-week fetus that was our index case. And you can see that there's retrograde flow in the arterial duct here, and that the tricuspid regurgitation, rather than coming from the annulus, is coming from way in the ventricle. So there's a right to left shunt, and there is also tricuspid regurgitation with corresponding increase in the size of the right heart structures, and also involving the left heart. In the middle is a 38-week fetus that died with so-called pulmonary atresia. The ductal pressure had held this pulmonary valve in the closed position, and it then became atretic. And there's just a Botkin in there to show you that the valve is atretic. And the echocardiogram in the short axis shows what I've already alluded to. Here you can see the descending aorta and the right to left shunt. And lastly, the so-called circular shunt with the blood coming from the ductus and going into the ventricle through pulmonary insufficiency. So this is a cycle of physiological development. Increased central venous pressure and venous flow and development of hydrops occurs. The right atrium is dilated. The right ventricle becomes dilated and thin-walled. There's decrease in forward flow into the pulmonary artery, poor development of the pulmonary valve and artery, pulmonary regurgitation, development of the circular shunt, functional or real pulmonary atresia, pulmonary artery fills retrograde from the ductus with more right to left shunting, poor ventricular function of the left ventricle with probably because of compression, ventricular-ventricular interaction, and the fact that Ebstein's malformation can be considered a cardiomyopathy and fibrosis. So that's how it goes. This is going backwards. I don't know what's going on with this machine. Okay, and then decreased coronary perfusion and cerebral perfusion and eventually death. But anywhere on the circle you get on, the whole circle of events occurs in Ebstein's. Now, I'll just bring out some of the things that we see with the ultrasound. Because the right ventricle is enlarged, it is frequently possible to see the right ventricle in standard ventricular views, like a parasternal view. And here's a specimen cut to show a parasternal long axis equivalent. And you can see the anterior, superior, inferior, and septal leaflets on a parasternal long axis. The right ventricle is enlarged, the left ventricle is compressed, and the right atrium is also large. And here is the echocardiogram showing the anterior superior leaflet, the inferior leaflet, and the septal leaflet plastered against the ventricular septum. This specimen comes from the Pittsburgh archives, was given to me by the late Bob Zuber-Buehler. And so this is in your archive over here and shows the position of the atrioventricular junction in red. I will not mention that again, but the AV junction is in red, and the displacement of the attachment is shown in green here. And the echocardiogram in that parasternal short axis shows the medial papillary muscle, anterior papillary muscles, so the anterior superior leaflet, the inferior leaflet, and also the septal leaflet, which is attached to the ventricular septum. You can see this from the apex. Here's a patient where we're looking at the apex of the heart in a normal, showing the medial papillary muscle, the anterior papillary muscle, and here's the posterior papillary muscle, so septal leaflet, anterior superior leaflet, and inferior leaflet. And all three of these can be seen on an apical displacement of the parasternal short axis plane. Now here are three comparisons between a specimen which shows the septal leaflet and the anterior superior leaflet. And note particularly these attachments of the abnormal anterior superior leaflet to the underlying ventricular myocardium. This was given to me by Dr. Justin Tretter, is an example of Ebstein's malformation. You can actually see the anterior papillary muscle here, attached here with the shadow of the valve. You can notice that there's also regurgitation in this area here. And the mitral valve is in its normal position. What you haven't looked at, which I'm going to interpret for you, is that there's also spongy myocardium of this patient. So this isn't just Ebstein's, but a variety of Ebstein's, a number of them, have also spongy myocardium or non-compaction of the left ventricle. And I think puts us in the idea that what Ebstein's may eventually be is a form of a cardiomyopathy. And then the echocardiogram shows the apical displacement of the tricuspid valve. The septal leaflet is plastered against the ventricular septum. And here is this huge sail-like anterior leaflet with its caudal attachments to the underlying ventricular myocardium. So here again is that frontal picture corresponding to the echocardiographic plane. And you can see the annulus, the septal leaf, the inferior leaflet plastered against the myocardium here. So this is all atrialized ventricle. There's the true effective orifice of the valve and the regurgitation going down towards the apex of the ventricle. In no other condition does tricuspid regurgitation present itself in a diaphragmatic position. And the diagram of Christian Shriver, which we've shown you, showing this valve. Now, I've done this with pathology to show the junction and the displacement of the septal leaflet. And here the whole valve leaflet teased open with the septal and inferior leaflets being displaced in the anterior superior leaflet in normal position. But we've used this previous picture that we've shown you of the orthogonal subcostal equivalent and the coronal, that's the coronal, and this is the sagittal plane cut. And you can see here that we can look at the annulus in 2 dimensions and see that this annulus is displaced in space towards the diaphragm, the outlet of the ventricle, and that the jet of regurgitation is always directed at the diaphragmatic surface of the right ventricle. Okay. Now, I call Ebstein's disease the dozen Ds, but since working with the De Silvas, I've added another finding, and so I've made this a baker's dozen, which is usually 13. So displacement of the proximal leaflets we've discussed, dysplasia of the valve, distal attachment abnormalities, and dysplasia of the underlying myocardium, and dysrhythmias because there's no D in arrhythmia. Wait a minute, Simone, I'll let you take a picture in a minute. So let's go through that again. Dysfunction of both ventricles, both systolic and diastolic, dilatation of right heart chambers, arterial duct associations, which we've seen, deformity of the right ventricular outflow tract and pulmonary artery, which we've also shown you, defects others such as ventricular septal defects and pulmonary stenosis. And now this is the 13th D, the 12th D is think De Silva operation when you look at this. And I don't mean that in some kind of a patronizing way, but what I think is important is that when you think of surgery today, you think of the De Silva operation, and you have to look at these hearts in the way that you can find and highlight these things for the operation. And of course, the last one that happens to all of us is death. And did you want that a picture? All right, I'll go back for you. Sorry. Very difficult to go back. All right. Okay, take a picture. Okay. All right. Are we all done? Okay, so now we're going to look at all of these things in sequence. So we're going to look at the displacement of the valve from its true position at the atrioventricular junction. And this gets worse and worse. So I've got mild to moderate, and severe displacement down towards the apex. And the displacement is because if you look at the right ventricle, the valve is moved into the outflow tract. So if you look at it in the long axis, you can miss it. In the four-chamber view, you may miss the valve and see what looks like a very small amount of insufficiency right at this region here at the cardiac apex, because the valve is displaced into the outflow tract largely. And there's this famous paper that followed our description of Ebstein's malformation, describing an index of 8 millimeters per meter square of displacement. And I just point out to you that this variable, this is the same patient. Here it looks small, here it looks large, because this is the front section over here, where the septal leaflet of the tricuspid valve is minimally displaced to its point of maximal displacement posteriorly, which allows you to do this. So if you're going to look at displacement of the tricuspid valve, you must angle your probe inferiorly in order to see this in the four-chamber view and record it accurately. So this is the same patient, the same sweep that is done on the same woman post a mother who was pregnant, and you can see that the displacement when you go back is much more than the displacement when you look at the front. So that's really an important caveat for the four-chamber view. And you can do the same subcostally, and you can see how the annulus rotates round, both on the specimen, which looks relatively normal, and you can see the anterior superior leaflet is fine, the septal leaflet is plastered against the ventricular septum, and here's the true junction and the annulus, and the mild, moderate, and severe displacement that occurs when you draw the annulus. And I've put the Schreiber diagram in there just to show you the variability of this rotation of the valve into the outlet chamber. The valve can be dysplastic. In fact, it almost is, as you've seen on many of the examples. And here you can see the so-called verrucous nature of the septal leaflet of the tricuspid valve. Here is the anterior superior leaflet, which is also thickened and rolled. And here I'm pointing out on this big say-like anterior leaflet, the tendinous caudal attachments to the underlying right ventricular myocardium of this anterior leaflet, as well as the abnormality on the septal leaflet. And when that get really severe, this is a neonate born with a severe Ebstein's malformation and non-coaptation of the tricuspid valve, begging surgical treatment. Here's the anterior leaflet attached to the underlying myocardium with very little motion to that large anterior leaflet. This is just aortic outflow, but you can see that there's almost nothing happening in this ventricle. And here is the displacement of the posterior leaflet or inferior leaflet of the tricuspid valve. Here again is you'll see the displacement of the annulus over here, drawn in of the valve attachments, not annulus. And here's the AV junction here, and the septal and the inferior leaflets. I'll just take the diagram off. So you can see the say-like and abnormal anterior leaflet, the septal leaflet and the inferior leaflet are seen there. Remember, when you're looking at a four-chamber plane, you cannot see the septal, the inferior leaflet, and you see just the septal leaflet attached to the septum here with severe tricuspid regurgitation, and also the attachments of the anterior leaflet to the underlying myocardium. Now, the distal attachments are also abnormal in this condition. Here is a fairly relatively normal anterior leaflet, and here is a linear attachment of the valve leaflet to the underlying heart. And this presents a problem for the surgeon, which we can see to some extent, and that this rotational and positional abnormality of the distal attachments is variable rather on a spectrum of conditions than a particular milepost of where they occur. But I've just used these examples of Ebstein's to show from relatively normal to linear attachment, with this being so-called hyphenated attachments of the ventricular leaflets of the septal leaf and the anterior leaflet. So here's that first picture that I've shown you, and matched this with an echocardiogram to show the functional right ventricle, the atrialized right ventricle, the tricuspid regurgitation jetting towards the diaphragm. And here's another one. You can see more severe tricuspid regurgitation striking the diaphragmatic surface of the heart. Here are subnormal, what we call hyphenated attachments, 1, 2, 3, and these down over here. One of these must be the anterior papillary muscle. There's the anterior superior leaflet. So this is septal leaflet with its hyphenated attachments. And here is an echocardiogram matched to this specimen. This is from the UC archive, by the way. And you see the anterior superior leaflet in the outflow tract, and the inferior leaflet, seen best in the subcostal coronal and sagittal views, is attached here with hyphenated chordae attaching and keeping this valve from being mobile. And again, another example showing the hyphenated inferior leaflets, the atrialized right ventricle and the functional right ventricle, which is really quite small. Here are some hyphenated attachments of the septal leaflet, both to the free wall and to the septum, going all the way around there. And here is an echocardiogram that shows those attachments. And here's one which is a halfway, showing the hyphenated attachments and the linear attachments of this valve in the same patient. And here we can see all of those hyphenated attachments underneath the anterior superior leaflet that will be removed as part of the De Silva operation. And then, of course, we can have the case where there's total attachment of the tricuspid valve to the underlying myocardium, producing a so-called tricuspid atresia. And here is an echocardiogram of such a patient. You can see very little function of the right side of the heart here. And the motion of the valve is largely the motion of cardiac motion rather than actually your ventricular motion. So that's pulmonary atresia. And here, just to show you that that can occur, here's a patient with pulmonary atresia, a young boy of 11 years of age, who also had isolated restrictive muscular ventricular septal defects, acting for this patient as a divine band, and he was actually living a reasonably normal life with a little bit of mitral insufficiency. But so you can have what looks like a normal prognosis with a clear Ebstein's malformation, but this is pulmonary atresia and only survived because of small muscular ventricular septal defects. Now, we talked about dysplasia, and here is an example of fibrosis of the underlying myocardium. This is looking at the diaphragmatic surface, and we're shining a light in the ventricle, and fibrous tissue transilluminates if it's thin enough. So that's an area of total fibrous replacement of the right ventricle, and would be also cobbled up as part of the De Silva procedure. And here's the echocardiogram showing you this apical thin area of the atrialized right ventricle in a live patient. So we talked about the pulmonary valve. You've seen this picture before. There's pulmonary atresia. At 20 weeks of gestational age, this patient had a beautifully normal opening of the pulmonary valve. But at 36 weeks, before the patient died at 38 weeks, this is what the motion of the pulmonary valve looked like in this very particular patient. So there's pulmonary atresia as a developmental problem, and one of the things to consider in this disease. So there are malformations that we know frequently affect left morphology, as we've mentioned, spongy myocardium, and the defects are invariable atrial septal defect, ventricular septal defects, pulmonary stenosis or atresia, and excessive trabeculations, which we formerly called spongy myocardium, Wolff-Parkinson-White, and of course, congenitally corrected transposition. So that's what I have to say, and I hope it's been useful to you. And I thank Dr. De Silva's, the two of you, for inviting me here today. And it's a real honor for me. Thank you.
Thank you, Dr. Silverman. That was fantastic. There will be more discussion in the panel a little bit later after all the presentations, and we address any questions then. Next presenter is Dr. Tariq Al-Said. He is a core imager in our institution, assistant professor of pediatrics at the University of Pittsburgh, and he will be talking about cross-sectional imaging in Ebstein's anomaly.
Terrific. Thank you very much, Jackie, and thanks for the organizers and to Dr. De Silva for having me today. I will be talking about the role of cardiac MRI in the pre- and post-operative management of patients with Ebstein's anomaly. I have no relevant disclosures except that it's really hard to talk after Dr. Silverman. That was such a wonderful presentation. All right, so over the next 10 to 15 minutes, we will talk about the role of cardiac MRI in the pre-operative evaluation of Ebstein's patients. We'll have some case presentation of the complementary role of echo and cardiac MRI, and we will talk about cardiac MRI post-cone in managing challenging and rare post-operative complications. But when we start, we all use our echocardiography as our workhorse for congenital heart disease, and in particular for patients with Ebstein's. And we think about cardiac MRI as this fancy car with all the bells and whistles that we may or may not need. And I hope that by the end of this presentation, we think about this relationship between echocardiography and cardiac MRI as a more of a collaborative love relationship. And with the excellence of our surgeons and the team in general, we can achieve the best outcomes for patients with Ebstein's anomaly. Okay, so let's talk a little bit more about cardiac MRI. So the pros of cardiac MRI generally in congenital heart disease is that it gives us quantitative ventriculography. It also gives us dynamic and flow data, and it's radiation-free. However, the cons of cardiac MRI generally is that it takes time to acquire, And also it requires the compliance of the patient, and sedation is often required, especially in younger patients who cannot hold their breath. In Ebstein in particular, cardiac MRI can be very helpful because it will give us a quantitative assessment of the right ventricular and the right atrial dilation. It allows us to evaluate right ventricular function, and it also allows us to look at the amount of leaflet tissue and the tissue attachments, as was shown very nicely by Dr. Silverman, and then also the structure and the attachment of these leaflets, and finally the valve rotation can be seen and measured by cardiac MRI. So when we're doing cardiac MRI for these patients, we use a general protocol that is published by the Society of Cardiac MRI, and we start with ventriculography. We look at the tricuspid valve cine images. We also look at the phase contrast imaging, which is the imaging to evaluate the flow across the tricuspid valve. And also we do contrast-enhanced magnetic resonance imaging and also 3D imaging to evaluate the 3D anatomy. So this is how that looks like. So we start typically with a 4-chamber view, and then from that 4-chamber view, we plan our short axis view, and then that short axis view is generally what we use to evaluate ventricular size and function. We take multiple slices, and we usually draw contours or circles around the ventricles in order to evaluate ventricular size and function. And that works pretty well in congenital heart disease in general, except in Ebstein's anomaly, because that tricuspid valve is so displaced that it's really hard to draw these circles and the contours in short axis. So to overcome this limitation, we actually go ahead and do a stack of 4-chamber images. And here we can see the hinge points of the tricuspid valve very nicely, and we can determine what's actually functionally right ventricle. And this is how we draw our circles to determine the functional right ventricle in order to tell you the size and the function of the functional right ventricle in patients with Ebstein's. And then after we do the ventriculography, we start looking at the tricuspid valve cine imaging. So we look at that in 4-chamber views, and then we plan our inflow, outflow picture that Dr. Silverman showed. So you can see the inflow here and the outflow is here. And then we go perpendicular to that, and that gives us a nice image en face of the tricuspid valve in these patients with Ebstein's. And then after we looked at the anatomical image, we look also at the flow image or the phase contrast imaging. And in this image, you can see the tricuspid valve here, and the blue color is actually the inflow. The red color here is the jets of the regurgitation. And we draw a contour around them over the entire cardiac cycle. And this is one way to determine how much regurgitation we have. Another way to determine how much regurgitation is by taking the stroke volume that we determined from the previous ventriculography from that 4-chamber stack, and then we calculate the tricuspid regurgitant fraction as the functional right ventricle stroke volume minus the main pulmonary artery flow, which we can quantify very accurately by cardiac MRI, and divide that by the functional right ventricular stroke volume. And then after we calculate that regurgitant fraction, we call it typically mild if there is less than 20% regurgitation, moderate if there is 20 to 40% regurgitation, and severe if there is more than 40% regurgitation. And now with the invention of the 4D flow, which we are using more and more, the 4D flow can more accurately measure the valve regurgitation with valve tracking. So we can track the valve over the entire cardiac cycle, and that will allow us to determine how much goes antegrade and how much regurgitation we have. So this is a case just to show how we put these concepts into practice. So this is a 12-year-old with Ebstein's anomaly, had progressive exercise intolerance and arrhythmia or dysrhythmia. He was actually diagnosed at 5 days of age when presenting with cyanosis, and started to have palpitations at age of 9 years, and then started having progressive exercise intolerance. And this is his pre-op echocardiogram. So you can see on this echocardiogram that this tricuspid valve is severely displaced, as you can see here, and also it's tethered to the right ventricular free wall. And then you see the atrialized right ventricle here, the severely dilated right atrium as well. And then when you put color, all we get is like these two relatively small jets of regurgitation. And that's, as Dr. Silverman showed nicely, because the valve is super displaced. And that can be challenging to evaluate the severity of tricuspid regurgitation by echo. So the echo read on this patient was that there was mild to moderate tricuspid regurgitation, while the RV function was moderately depressed. And that was mostly qualitative. So as part of our protocol, we do cardiac MRI on patients preoperatively, and this is that 4-chamber stack. You can see the phase dispersion consistent with regurgitation. And then we use these methods we just talked about to determine how much regurgitation there was. And actually, the regurgitation was thought to be severe by cardiac MRI with a regurgitant fraction of 46%. The RV was measured to be moderately dilated. This is the functional RV I'm talking about, with an RV end diastolic volume of 146, with mildly depressed function and ejection fraction of 44%. So by MRI, this patient had severe tricuspid regurgitation and quantitatively had a mild RV dysfunction. Just like to remind you, with echo, we just got mild to moderate regurgitation as opposed to severe by MRI, and the RV function was thought to be moderately depressed. And this is not a common scenario where we have some disagreement between echocardiography and cardiac MRI before the cone operation, and that's why we feel that both modalities are complementary. And one of our fellows actually looked at that particular question, like how much agreement do we get between echocardiography and cardiac MRI when looking at the at both modalities before the cone operation. And he looked at 49 patients with a median age of 15 years. The data was presented at the Society of Cardiac MRI meeting last month. And we found that there's only weak positive correlation between the functional measures by echo, namely the right ventricular fractional area change by echo and the right ventricular ejection fraction by cardiac MRI, which is this graph here. And then you can also see that the tricuspid annular plane systolic exertion or taxi by echo and the ejection fraction by MRI only had weak correlation. Importantly, we couldn't measure TAPSI in 10% of our patients, and we couldn't measure the fractional area change in 50% of our patients. And that highlights the difficulty of these measurements by echocardiography because of the right ventricular dilation and the right atrial dilation. And the only functional measure that correlated with RV dysfunction after surgery, which is something we see in some cases after the cone operation due to RV fibrosis, is the decrease in RV ejection fraction by CMR, which had significant association with post-op RV dysfunction. And there was poor agreement between the two modalities in terms of TR severity. And we found that there was 12 patients who were graded moderate or less by echocardiography, and by MRI, when we do it, it was severe regurgitation. So what we concluded from this study is that there is weak correlation between echo markers of RV function and RV ejection fraction by cardiac MRI, which is considered to be the gold standard for RV function in congenital heart disease. And there is also poor agreement between echo and CMR assessment of TR severity. And the decrease in RV ejection fraction on pre-op cardiac MRI was shown to be significantly associated with post-op RV dysfunction. And because of that, CMR is an important tool for preoperative assessment in Ebstein's anomaly and may help with postoperative risk stratification. So that concludes our first case. And then our second case is a patient who had symptoms that worsened after having the cone operation at another institution. So this is a 9-year-old who had cone operation at another hospital a few months ago, but he continued to have worsening symptoms after the cone operation. And you can see on this parasternal long axis picture by echo that this is the anterior hinge point for the cone. while you can see here that there is a gap between the posterior hinge point of the cone and the inferior wall of the right ventricle. So there is a dehiscence of the cone resulting in torrential tricuspid regurgitation in this patient. Just looking at these images by echo, you can see nicely that there is dehiscence of the cone resulting in a gap here between the cone and the inferior RV wall. And then when we put color, there is torrential tricuspid regurgitation consistent with cone dehiscence here. And by short axis, we can see the same thing. As we sweep inferiorly, there is no tricuspid valve, and it becomes almost like an unguarded tricuspid valve with torrential tricuspid regurgitation. So in this case, there was a cardiac MRI done in the outside hospital before the patient got to us, and that was very helpful to see. So we can see that the right ventricular size is like severely dilated. The right atrium is severely dilated as well. We can see that as we go inferiorly, there is no tricuspid valve tissue. But importantly, what Drs. De Silva noticed is that there was still some tricuspid valve tissue here towards the apex that was not delaminated in the first surgery, and this can be used to re-repair that tricuspid valve. And because of that, we proceeded with the De Silva cone operation. So this is how there was a cone dehiscence before surgery, and this is how the tricuspid valve looked after surgery with only trivial regurgitation. You can see that the RV function was severely, or the RV size was severely dilated, the RV function was severely depressed, and you can see some improvement in the RV size and RV function after surgery. But to quantify that, we decided to go ahead and get a cardiac MRI after surgery, after the second cone operation, and you can see that the RV continues to be significantly dilated, and while the RV function improved slightly, it continues to be severely depressed. But you can see nicely the hinge points of that cone to the anatomical annulus of that tricuspid valve. Okay, so I hope over the last 15 minutes that I could convince you that cardiac MRI and echocardiography had a complementary role when taking care of patients with Ebstein's anomaly, and with the excellent surgeons, we can get to the best outcomes of patients with Ebstein's anomaly. So the conclusion of this talk is that preoperative cardiac MRI should be used to determine surgical candidacy, RV function, and valve anatomy in Ebstein's anomaly, and complements echocardiography. And both pre and post-operative Ebstein's patients require longitudinal cardiac MRI follow-up throughout adulthood, especially if complications are identified. And with that, I would like to thank all of you. I would like to thank the organizers and our wonderful Ebstein's team and the Silva Ebstein's Center. Thank you, guys.
Thank you, Tarek. That was spectacular, those cases. So our next speaker is Dr. Sara Trucco. Dr. Trucco is Associate Professor of Pediatrics at the University of Pittsburgh. She's also co-director of the Cardiac Cath Lab and director for QI for Cath. And Sara will be talking about the role of heart catheterization.
Thank you, Jackie and Dr. De Silvas, for having me here today. How do my slides come up? Oh, great. All right. So in preparing for this talk, I had our research coordinator pull all of the cath patients that came to the lab with the diagnostic code of Ebstein's anomaly. And if you look going back 10 years, for many years, we only had 5 to 7 patients come through the lab with this diagnosis. Subsequently, this is when Dr. De Silva arrived to Pittsburgh and the De Silva Center was founded, and we had an exponential growth of cath referrals with 40 cases coming through the cath lab in 2023. So what do we do in the cath lab for these patients? So we evaluate them both preoperatively and postoperatively in ages ranging from infancy to adulthood at various stages of palliation. And the majority of the cases are diagnostic with the main focus on pulmonary blood flow and pulmonary vascular resistance, though there are a series of interventional procedures that we can perform. It is incredibly rare to need to cath a newborn infant with Ebstein's, but there were 2 cases over the last 10 years, 3 if we include one that had a dysplastic Ebsteinoid-like valve. But the 2 cases I'll talk to you about today, one had anatomic pulmonary valve atresia, and what we could do in the cath lab is offer an alternative to a BTT shunt by providing a ductal stent. So if you look here at the first panel, that's what the ductus looks like. You see the massive cardiomegaly on the X-ray, and on the lateral panel, there is here the ductus, and this is what it looks like straightened up after the ductal stent was implanted. The functional pulmonary valve atresia case, this was a newborn that presented with extreme cyanosis, and we tried to do some manipulative maneuvers such as placing the patient on INO or reducing the PGE to try to promote forward pulmonary blood flow, but that did not work, and the patient was placed onto ECMO. And they came to the cath lab to assess the pulmonary pressures to try to determine why they were so cyanotic. And if you look here on ECMO, the saturations are normal, but that's the oxygenator doing their work, but the pressures were really normal in the lungs. So then we clamped the ECMO in order to see what the patient was doing on their own, and they became profoundly cyanotic, but the pressures remained normal. So pulmonary hypertension was not this baby's problem. What they needed was another source of pulmonary blood flow. When you look at this right atrial angiogram, you can see that there's very little blood making it to the RV or the pulmonary arteries. But we were able to cross the tricuspid valve and show that there's a nicely well-developed right ventricular outflow tract. The pulmonary valve opens and the pulmonary arteries were of good size. And this shows you what the RV inflow, or the atrialized portion of the right ventricle, looked like. So this patient ended up getting a BTT shunt, which allowed them to come off of ECMO and eventually have a cone. So in preoperative cath, what are the indications when you're outside of the neonatal period? We get patients referred of all sorts of ages. One of them is cyanosis, where we really want to know, why are they cyanotic? Is it due to low pulmonary blood flow, high pulmonary vascular resistance, or do they have an ASD with significant tricuspid regurgitation leading to right to left shunt? Additionally, if there's ventricular dysfunction, we want to evaluate the filling pressures for diastolic dysfunction, occasionally coronary angiography to look for a cause for systolic dysfunction. If we're unsure of the pulmonary pressures, evaluating their reactivity to oxygen and nitric oxide can be helpful in the postoperative management. And then we look for the associated anomalies that were mentioned in prior talks today. And then in our institution, we have been doing combined electrophysiology studies for patients with histories of arrhythmias. So they come to the cath lab, I do the diagnostic portion with some angiography and any required intervention, and then the electrophysiologist performs the EP study and ablation so that everything is performed under one anesthetic and one procedure. This is an example of a 3-year-old patient who had cyanosis and came to the lab prior to their cone procedure. If you look, the hemodynamics are relatively good, but the QP was quite low. So the pulmonary blood flow was quite low, the ratio of pulmonary to systemic blood flow was low, and the pulmonary vascular resistance calculation came out to be slightly elevated. So we did place the patient on nitric oxide, and although the QP didn't normalize completely, it did come up, as did the cardiac index. So the ratio did not improve, but the pulmonary vascular resistance fell to the normal range. So this was helpful in providing the patient nitric oxide following their cone procedure in the early perioperative management. This is another patient who was a lot older and came to us prior to the De Silva Center being founded. She had cyanosis with exercise. Her tricuspid valve regurgitation was relatively mild, but she had an atrial septal defect. Her hemodynamics were pretty normal, and so we decided to close her ASD, which was first test occluded, balloon sized, and then closed here with a Gore cardioform device. Nowadays, this is not what we would do. We would actually proceed with cone because there are benefits to remodeling the right ventricle long-term that can't be achieved in the cath lab. So actually, just a few weeks ago, we had a similar patient show up who was now in her late 40s. She had had her ASD closed decades prior with this device called the CardioSeal, which is no longer used. And she, over the course of her lifetime, developed severe TR, arrhythmias, RV dysfunction, and so she ended up coming and being palliated with a cone. So our practice now is, if you have a significant Ebstein's, we would rather have you have a surgical ASD closure at the time of your cone procedure. My colleagues talked about how you see Ebstein's on different imaging modalities earlier today, so this is what it looks like on cath. This is a catheter in the right ventricular outflow tract. You see it's very dilated. This is where the valve is sitting, and this is where it should be. So this gives us the tricuspid rotational angle that was nicely described by Dr. Silverman. This is a more mild version where the angle is much smaller. And here's a more severe version where the angle is quite wide, and you can see the attachments have been severely apically displaced and rotated out towards the outflow tract. Another finding that's seen on angiography is compression of the LV from the massive cardiomegaly. This is a patient that had a lot of RV dilation and led to some LV compression. This is a patient with much more significant tricuspid regurgitation. So although their LV dilation, I don't know why it won't play. There we go. Wasn't quite as bad. Their cardiac output was fairly low, probably due to the massive TR. So moving on to postoperative management, the indications for what we do really depends on what stage of palliation the patient is, and we'll go through each one. So in the post-BTT shunt, PDA stent, or STARNS patients, we're really evaluating their hemodynamics to see if a Glenn is necessary, are they a Glenn candidate? And then we also look at the RV pressure and RV angiograms in the STARNS patients. We look at PA anatomy that can be distorted following some of these palliations, and look at venous collaterals that can interfere with Glenn physiology. So this is a patient, international patient that came to us from Poland who had fairly good hemodynamics. It was now a toddler and had had a BT shunt not years, but many months before. And the only finding on the hemodynamics was mild RPA stenosis, which you see here. And when you look at the BTT shunt, it has become quite small over time and it has tethered the pulmonary artery. So this was relatively mild, but it's still something you want to evaluate the PA anatomy prior to going to the operating room in any of these patients. This is a patient who had pulmonary atresia and came to the cath lab, and you can see that the RV pressure was about half systemic. The significance of this is a little unclear. The blood doesn't have anywhere to go. But when you look at the rest of this patient's hemodynamics, the pulmonary vein pressure was quite elevated. So aside from just LV compression, other left-sided structures that can be compressed, which are likely more important, are pulmonary vein compression that can lead to acquired stenosis. So this patient did have stenosis of the left-sided pulmonary veins, went on to have a cone with the BTT shunt takedown, and then had exploration and opening of this orifice. They didn't come back to our institution for several years, and I don't know why it won't play. Let me see if I click here. Good. And had developed near-atresia of the left-sided pulmonary veins. And through aggressive ballooning, stenting, redilation over the course of over a year, we were able to rehabilitate that pulmonary vein. But this is to tell people that if you do have pulmonary vein stenosis, you need to be vigilant in monitoring it for recurrence. For the Glenn patients, we evaluate their hemodynamics to see if they should go down a single ventricle route with a Fontan, a 1.5 with a cone and a Glenn, or can the Glenn be taken down and become a 2-ventricle circulation. Test occluding the ASD can be helpful in making this decision. And then in this physiology in particular, we need to evaluate for decompressing veins and aortopulmonary collaterals that can develop, especially in the right lung. And then look again at the pulmonary artery anatomy. So this is a patient who had a very low RV pressure despite having a Starnes, and it's because they had no pulmonary atresia. They had a nice, beautiful pulmonary outflow tract and good PAs. So they went on to have a cone with a Glenn takedown. This patient came to the cath lab because of cyanosis. They had a Glenn, but they had had their ASD closed with a device, and so in theory, their saturation should have been normal. Instead, they were satting in the 80s. So the question was posed, do they have pulmonary hypertension, pulmonary AV malformations? Why are they blue? So pulmonary angiography showed good PAs with normal transit time. We did a bubble study that showed no AVMs. And then this is the angiogram showing severe tricuspid valve regurgitation. But when we went on to take a picture in the innominate vein, they had developed large decompressing veins that drained to the pulmonary venous system. So this was coil occluded, the saturations improved, and they also went on to have a cone down the road. Following cone, the indications for cath are similar. Again, we look for the hemodynamics, if there's an ASD, whether it should be closed, if there's a Glenn, are there any decompressing vessels, looking at the pulmonary artery anatomy, and then this is the cohort where we occasionally are asked to look at the coronaries following a procedure. So this is a patient that came to the cath lab following cone because of cyanosis. You can see that they do have pulmonary vein desaturations in the 80s, and the systemic sat was in the 70s, relatively good pressures. And therefore, we put them on oxygen because the QPQS was only 0.5 to 1. So with oxygen, the pulmonary vein saturations came up nicely, but the QPQS did not change significantly, and neither did the systemic arterial saturation. So we decided this patient required more pulmonary blood flow. The RV was likely somewhat stiff and not providing enough forward flow. So this patient did go on to have a Glenn in the post-op cone procedure period. However, a few months later, with some remodeling in time, the patient was referred back to the cath lab with complaints of high pulsatility in the neck veins. And you can see now that when we take a picture here, there is pulsatility to the pulmonary arteries and washout here through the Glenn. So the patient ended up having a Glenn takedown and is now a two-ventricle physiology with saturations in the high 90s. This is a patient who took a little longer to reequilibrate, so to speak, had some mild desaturation at baseline, but more so with exercise. We cathed them in order to see if we could close the ASD. And the first time they came to the cath lab, the cardiac index dropped significantly, the RA pressure rose dramatically, and so ASD closure was not performed. We gave them some more time, and then at the time of this cath, the cardiac index was maintained with closure, or with chest occlusion, and therefore we were able to close it. Finally, with the last couple minutes, coronary angiography. So anytime a patient comes to the cath lab with Ebstein's prior to surgery, I always try to look at the coronary arteries either with an aortic root or selectives, depending on their age. And if you look here at this pre-op image, the coronaries are stretched over this large, large heart. And then imagine it being a balloon that gets deflated with the cone procedure, plication of the RA and the RV, and you still have the same coronary mass and coronary length. So they end up with this tortuous appearance. So once or twice we've had to cath patients for coronary concern following cone procedure, and what we found is this tortuosity, not any actual stenosis or obstruction, and this patient was able to come off of ECMO shortly thereafter. Finally, tricuspid valve replacement. So there are some Ebstein's patients that come to us that have had a valve replacement either in a different era or at a different institution. And we are able to help these patients as well in the cath lab. So this is an adult patient who had significant arrhythmias and a lot of symptoms with inability to exercise. On the cath table, their gradient was about 8, which may not be that severe, but they were hypotensive under general anesthesia. So this was a real gradient. So we went on to dilate the valve and then implant a sapien valve in that position. And we were able to abolish the gradient, have no regurgitation, and this was with good hemodynamics. So in conclusion, Ebstein's anomaly offers significant hemodynamic complexity, and the cath lab is able to evaluate and provide useful information both preoperatively and postoperatively. And we're also able to offer transcatheter therapies that can be life-saving and may allow for better outcomes. Thank you.
Many thanks, Sarah. Don't go far because I think we have a panel discussion. And thank you, Sarah. That was fantastic. We are going to proceed with the panel discussion and address some of the questions that were brought up online and any questions that may be brought up here as well. So please, I'd like to invite the panelists, Dr. Jackie Weinberg, Dr. Jose Pedro da Silva, Dr. Norm Silverman, Dr. Sarah Trucco, and Dr. Tarek El Said, as well as Dr. Simone Pedra, who is a guest from Brazil, to join this section where we'll discuss mostly focused on imaging and some of the presentations we have heard. And also, please feel free, the members of the panel, to ask questions yourself to each other, because I know that may also be the case that comes up. First, there is a question about the role of umbilical Doppler on fetal assessment of Ebstein's anomalies. Or Jackie, if you'd like to comment on that, please.
I'd love to. As I talked about, the most severe complication that we see in fetuses with Ebstein's anomaly is the development of a circular shunt. And again, the development of pulmonary insufficiency can be ominous, but a true circular shunt, to assess for steal from the systemic circulation in the fetus because of that pulmonary insufficiency and backwards flow in the ductal arch. The true assessment of the steal from the baby is with assessment of the arteries. In my mind, the easiest one to look for is the umbilical artery, because we assess that in every single fetus, whether they have cardiac disease or not, when we do a fetal echo. And when we Doppler the umbilical artery, you should see continuous antegrade flow throughout diastole. And in the one image, I showed a couple of images where you can see that normal pattern. And truly, when you see cessation of flow in diastole or reversal of flow, that is an indication that the flow is being stolen from that artery and going backwards through the right side of the fetal heart. Other assessments can be made with the middle cerebral artery Dopplers on the fetal brain, or in the fetal aorta distal to the ductal arch. If there's truly reversal of flow in the descending thoracic aorta at the level of the diaphragm or in the abdomen, that would also be an indication that the flow is being stolen from that systemic circulation. So it's an easy way to look for those very the sort of worst case scenario for those babies.
Yes. I don't know, Simone, if you want to comment on anything, since you have a lot of experience in Sao Paulo.
Yes, I think another important feature is when you assess the RV regurgitation, there's a very low pressure. So those fetuses that have very low pressure, when you assess the TR, they are at risk for circular shunt. So I think this is a very important information too, besides everything that was talked here.
Yeah, wonderful. All right, the next question in the chat was specifically for Dr. Silverman. I think the question is not showing up in here, but there was a question about especially whether this is a mitral, something about this. Where did it go? I'm moving it. Oh, about the mitral valve and the tricuspid valve. It's disappeared. This mouse? Okay. The septal tricuspid leaflet and the anterior mitral valve leaflet share a common origin in the bridging embryonic leaflets. Yet, how often is the mitral leaflet affected? Do you think Ebstein's is more of a leaflet or myocardial wall problem, or both? Is it a late post-embryonic issue considering how often is the mitral valve effective in this structure? Is it a leaflet to wall interaction problem? Any thoughts on that, Dr. Silverman?
The mitral valve seems to be of little importance in my broad experience of Ebstein's malformation. We know in tricuspid atresia that there's frequently abnormalities of the mitral valve. So I would suspect that there would be also some minor abnormalities in Ebstein's, but I have not really
We don't see that.
found that to be a significant problem. The question of whether this is a valve abnormality or a myocardial problem is a very difficult one to resolve. I think both are involved.
Right.
And Tariq, you showed some magnificent pictures of the septal dyskinesis that occurs in this condition. So the other thing about the left side of the heart is it's not normal, because the normal left side of the heart normally sees the right ventricle on the other side of it. But in Ebstein's malformation, it sees the right atrium or the atrialized right ventricle. And so there is often a dysfunction on the right side of the heart, which I think is very much improved when you do a cone procedure on these patients and you put the valve back and also take care of that abnormal myocardium by doing an annuloplasty of the valve. So I think those are the important issues. The thing about whether the valve leaflets, the central fibrous body or the skeleton of the fibrous skeleton of the heart is uniform, but the septal leaflet of the tricuspid valve is only a small part of the problem. And I think I showed you this begins not in the embryo, in the fetus, after the formation of the tricuspid valve in its normal position. The valve leaflet is adherent to the underlying myocardium, and it's that makes it break down. As far as function is concerned, there is 15% from the Mayo Clinic's findings of spongy myocardium, or whatever you want to call it, hypertrabeculation, whatever, that occurs in Ebstein's. And I think we showed you beautifully that this can occur in the fetus as well. And I think that the one thing about breaking the talks up like this is that this is really a condition that is a spectrum from the time of embryology all the way through postnatal development.
Absolutely. Yeah, it's beautiful. That's very true. Yeah, and hopefully.
May I comment? Yes, I think that's correct. Ebstein anomaly involves the trachea valve and also the myocardium of the right ventricle. And secondarily, it can affect the left ventricle because the septum can be shifted to the left. And so the filling pressure, the volume of the left ventricle is decreased in diastole. So that also is an important issue. What we see in case where you have a good mobility of the anterior leaflet, then you have a good papillary muscle, usually. And in that case, that area of the right ventricle tends to be normal. When we have the linear attachment, and then usually the valve cannot have no inflow in the anterior area of the right ventricle, and the inflow occurs mostly near the outflow of the right ventricle. So those patients the heart does not enlarge much. So it's tough to say how bad is the right ventricle because it does not enlarge because the tracheal valve tissues are holding together. So by looking, if we have tricuspid regurgitation, then the outflow tract of the right ventricle tends to dilate. And then it can get more dysfunctional, that area especially. And finally, by dilating the outflow of the right ventricle, you have functional pulmonary regurgitation. And that makes everything get even worse. So one thing that the cardiologist should look is the condition of the outflow tract of the right ventricle. If it's dilating, it's a bad sign. You have to intervene as quick as possible because the prognosis can be altered if that goes too far.
Wonderful. Thank you. Okay. Yeah, you want another comment? Or yeah.
I'll tell you what bothers me about the surgery of Ebstein's is something that I don't understand. Maybe you can help all of us. When you do a cone or you do a stance procedure, which is closing off the tricuspid valve, the echocardiogram shows the right ventricle shrinks down in size dramatically. What is the physiology that causes the right ventricle to suddenly shrink down, or in, let's say, the stance procedure, or in a cone procedure?
I think with the cone procedure, sometimes initially you can have even a larger RV because you take down the anterior leaflet that is very tethered and the inferior leaflet too, so that area tend to bulge, tend to balloon, and that so we do some maneuver to prevent that, but then sometimes, most of the time, they dilate, so they end up with a bigger RV in the beginning. But then later on, it tried to reverse remodeling in most cases. Now, regarding if the valve is well, is well repaired with no regurg, especially, and no pulmonary regurgitation too. So now, when you think in the Stern procedure, then what you do, you exclude the RV almost totally. You leave just a little hole of 4 millimeters. And so the inflow to the right ventricle is just 4 millimeters. So what happens is that the end diastolic pressure goes down. If it was like 12, it goes down to 3, 4. So the ventricle tends to shrink because of that. And then it does not generate pressure too much, much pressure, because the feeding pressure is very low. To generate pressure, then what you need is more feeding pressure, and the valve has to be competent. If you have, by doing the Stern, if the tricuspid valve come together and become more competent, then you can have less regurgitation, so you can generate some pressure more pressure, I would say, higher pressure, in the functional right ventricle. The other way to measure it, if you don't have any tricuspid valve competency, so you can look at that, at the hole in the patch, in the Stern patch. But that will be most of the time low pressure. So doesn't mean that the ventricle cannot be recovered. So that's why it makes it very difficult to indicate the operation after this Stern. I think we're going to have time to discuss that a little more, but evaluate the RV function after the Stern is very difficult.
Mm-hmm. Okay. Yes. There are some questions on MRI, Tarek, especially there's some questions about the correlation MRI and echo, and I know you commented on that, whether there is any cutoff of RV index and diastolic area on echo that you could use to correlate with RV and diastolic volume on MRI. That was one of them, and then some more about the role of MRI. Yeah.
Like oftentimes the challenge we have by echo is that we don't see the RV free wall very well in the fourth chamber in order to measure an accurate RV and diastolic area by echo. So that's why like in 50% we couldn't get the RV fractional area change in these patients. Mm-hmm. Generally speaking, we use an area below 35% by echo to determine dysfunction, and less than 45% by cardiac MRI for ejection fraction to determine dysfunction.
Wonderful.
Can I just ask one question of both the physiologists, the cath people, and the surgeons? Is how do you decide when to put a device in the atrial communication? Because we've had patients where we've done that, and the next morning the device is in the pulmonary artery, because basically the atrial septal defect or the communication is a pop-off valve. And when you need it, you need it. Of course, if you don't need it, it's easy to close. So what is the parameters of function that you use to find this indication to close or leave the defect open?
So is this on? In the cath lab, there's anatomic and physiologic parameters. So obviously you have to have enough tissue to hold on to a device so that embolization is less likely. But we test occluded and we see if the cardiac index drops and if the right atrial pressure increases significantly, then that's a contraindication towards closing it. If they have significant pulmonary hypertension, that's an indication for not closing it. And more times than not, now that we have the cone procedure as an option, if they have any indication for proceeding for surgery or a cone, we don't put a device in. We allow the surgeon to close it because they can either close it completely or at least make it smaller and fenestrate the defect if they do need a pop-off, but a smaller one so they're not as cyanotic.
Okay, thank you.
Yeah, one of the limitations, obviously, in the cath lab, it's very difficult to leave a small defect, right? We usually close it, and the surgeons can do that very nicely according to the results of the operation and figure out you can leave a pop-off. And sometimes those can close off on their own over time if they don't need them. But yeah, exactly what Sarah said. Okay, wonderful. I think that one of the questions that I think Jackie was bringing up for Tarek, I don't know if you want to go ahead and ask, but there's some questions also in the chat about the role of MRI, whether we should develop some protocols for using MRIs, since that appears to bring such valuable information that may actually play a role predicting outcomes longer term.
Yeah, so like before surgery, we always do a cardiac MRI if we can, and we do that in all adolescents and adults who don't need anesthesia. In smaller kids, we do it, on a selective basis, and if they are getting any other procedure that requires anesthesia, typically we go ahead and do the cardiac MRI, and we find that the information adds up to the echo information and can give some prognostic value later on for RV function in particular. Post-cone, we've been trying to do a cardiac MRI if they are local 1 year after the cone operation, and then periodically every 3 to 5 years, mainly to kind of like continue to follow up on the RV function and to evaluate the RV and RA size over time.
Wonderful. I think we're going to have to move on to the next session. But thank you very much to all the panelists, and some of the questions that we were not able to answer in the discussions, we will address online. So thank you. We will be proceeding with the next session, and Dr. Laura Olivieri will be presenting, will be moderating the session. Dr. Olivieri is Director of Imaging at UPMC Children's Hospital, and she's Associate Professor of Pediatrics here at the University of Pittsburgh.
Thank you so much. Good morning, everybody. I'm very honored to be moderating this next part of our session, which is really a special part of the session regarding staged treatment of Ebstein's anomaly. So it is my pleasure to introduce our next speaker, Dr. Joan Sanchez de Toledo. He's an assistant professor of both pediatrics and critical care here in Pittsburgh at UPMC. He will be joining us remotely to discuss the critical care management of neonatal Ebstein's anomaly.
Thank you very much, Laura. I think that you can see my presentation.
Yes.
And you can hear me well. I don't know if you can see me, but that's not important. The important is the slides. So thank you very much for the kind introductions, and thank you very much to letting me participate in this symposium. It's a true privilege, and I'm very honored to be here with all of you. I have 13 minutes to talk about management of neonatal Ebstein, and I think that what we'll try to do over these few minutes is summarize those 4-5 things that you see in the slide. We'll talk about the importance of risk stratification. We'll talk about postnatal physiology and the impact of this physiology on our management in the ICU. We'll give you some tips or practical guidelines on medical management, and then we'll present the algorithm that we have defined here in Pittsburgh the last years of experience. As we all know, we're talking about a difficult entity that has a variety of presentations due to this particular anatomy. But we all know that the neonatal presentation and the neonatal presentation usually connotes the more severe disease. And this is particularly important, and this will lead the further discussion. And we hope that during the panel discussion we can expand a little bit about those things. There's several publications. There's multiple multivariate and multi-center studies that talk about the risk factors prenatally. And if you analyze all those publications, they all end up talking about the same thing: prematurity, the presence of pulmonary valve regurgitation, the presence of tricuspid valve regurgitation, and the presence of pericardial effusion or hydrops as well. So, well, those things, prematurity, anatomical valve dysfunction, pericardial effusion, they talk about 3 important concepts that leads the physiologic dearrangements of these patients. Gestational age tells us about PVR, a difficult transition to the newborn life, increase pulmonary pressures, increase load to the lungs, difficult to ventilate, so increase PVR. The second, that both the PV and the tricuspid valve regurgitation leads us to the circular shunt concept. And last but not least, the presence of pericardial effusion, which is the extreme form of congestive heart failure, which is in fetus life, what we can see, or we can call hydropic babies. So we need to understand what the circular shunt is, and this is why the previous panelists and the previous speakers have very well described the physiology behind the circular shunt, conditioned by the presence of the PDA, the tricuspid valve, and the pulmonary valve insufficiency. And then the presence of the congestive heart that it's easy to identify on an X-ray, huge heart, huge liver on exam, and this is a common feature of all these very sick neonates. And also the concept of PVR and how the PVR relates to the understanding of cardiopulmonary interactions. And this is probably one of the most important things that the bedside physician needs to take into account when he wants to manage those patients. So if we put together the anatomy and the physiology, we know now that the more severe anatomic variants of Ebstein's involve those with severe tricuspid regurgitation, severe congestive heart failure with cardiac dilation, and obviously those with reduced or non-existent pulmonary antegrade blood flow. And we know that the progressive congestive heart failure with dilation of the heart leads to what we knew on the previous slide, it's difficult cardiopulmonary interactions, and the interventricular dependence will hamper the function of the left heart, decreasing further the left cardiac output. And as well, the progressive cardiac enlargement will have a deleterious impact on pulmonary lung inflation, also contributing to increasing the PVR and increasing the afterload of the right ventricle. So when we talk about pulmonary management of those patients, and excuse me if I'm very broad, but I think that those are the concepts that we have to take into account. Pulmonary vasodilation to promote anterograde pulmonary blood flow. And I don't want to go into how much oxygen, how much NO. So we need to promote pulmonary vasodilation, but also we need to treat congestive heart failure. And I will give you a couple of important concepts related to that in the next couple of slides. But then another important thing, and it's something that Dr. Trucco alluded to on his in her previous presentation, is how we're going to use prostaglandins in these patients. When it's time to stop prostaglandins, what is the deleterious effect that prostaglandins will have in a patient that needs the prostaglandins? When to stop it, when to slow it down. And then two important things. What about pressure, positive pressure ventilation? What about volume, right? So at the end is pulmonary vasodilation, congestive heart failure, and judicious and rational use of prostaglandins. And I want to mention, and I want to focus on that slide, because we all know, and we have all been told that volume saves lives. But listen, since 2005, cardiac intensivists insist that volume overload is not good, and that volume overload is associated with mortality to our patients. So in a patient with congestive heart failure, giving volume and chasing volume to numbers that we don't know exactly what they mean, such as the CVP, will end up creating problems. Pulmonary edema, pleural effusions, pericardial effusion, and that's why these patients develop a severe hydrops in utero. And I mentioned that it took a while to realize that what we did to save lives was indeed causing problems. So we all know now that before pushing too much volume in an ICU, you need to assess the heart. So these patients, and particularly the ones that suffer from right-sided congestive heart failure, are the ones that are more vulnerable to the judicious volume resuscitation. So please, 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 just take a minute before giving volume to those patients. And the same thing applies to the positive pressure ventilation. Remember that this is a passive, almost a passive flow to the lungs. And the venous return is severely hampered by positive pressure ventilation. And if we all know the venous return equation, which is the ratio between the gradient between the mean systemic filling pressure and the right atrium pressure, the more increase or the higher increase of the right ventricle afterload, the further will decrease the venous return. So every single time that you put one of these patients on a positive pressure ventilation, you have to think that you will suffer from venous return, which indeed is the cardiac output of these patients. And it's important to understand what we have here in the right side of the slide, which is the relationship between PVR and volume expansion. We always want to live in the FRC zone. A patient that is severely expanded will have increased PVR, but the one that has atelectasis has also increased PVR. So try to always keep your patient in the FRC zone. This is a simple way to think in a practical manner how to manage those patients. Obviously, a patient that is stable doesn't stay a long time in the ICU, so it's not worth talking about the left side of this graph. But when a patient is unstable, and you have to start medical management in the ICU, you have to think about the three concepts that I alluded first. Do we have circular shunt? Do we have pulmonary vascular regurgitation? Do we have tricuspid valve regurgitation? Do we have functional or anatomical pulmonary atresia? And if so, then try to promote anterograde pulmonary flow and stop prostaglandins. Try to stop progressively the prostaglandins to see how the improvement of pulmonary flow will sustain this patient cardiac output. So we all know that there's this subset of patients that are hemodynamically unstable due to the circular shunt that will give us a very, very, very hard time to manage them in the ICU. So before putting them on ECMO or before sending them to the operation, the theater, what we need to do is think about methods to restrict the ductal flow while we promote at the same time a pulmonary vasodilation. This is probably the most challenging thing, trying to combine ways to restrict PDA size, but also promote pulmonary blood flow. Those are complex patients to manage, and this takes time, experience, and multidisciplinary work with all the surgical team and the cath and the cardiology group. I want to mention this because, as we all know, this is a fetal problem, and the circular shunt appears on the more severe patients and are oftenly fertile fetuses. And we have all read about the challenge with indomethacin in utero, but what about those patients that cannot receive indomethacin, and what about the side effects of indomethacin itself? And this is a recent paper about the use of hyperoxia to promote pulmonary vasodilation in utero to eventually promote a pulmonary blood flow. Again, this is going back to the basics, going back to the physiology, and trying to combine those three things, those three concepts that I said, in order to promote cardiac output to those patients. Therefore, we know that the varying spectrum of presentations and the physiology of neonatal Ebstein's anomaly demands a tailored approach to the management. We have to take the risk factors into consideration. We have to study the anatomic features of each case and understand the derived physiology, which will help individualize the postnatal care. And at the end, again, we need to focus on promoting pulmonary flow, think about avoiding mechanical ventilation as much as you can, think about early initiation of pulmonary vasodilators. We have to treat congestive heart failure. We don't need to push volume. We need to diurese these patients. We need to avoid fluid overload. And we need to use judiciously vasoactive and inotropic support. Which ones? I don't know. Whatever center protocol has. But we need to promote left heart function, and we need to promote venous return. Choose whatever you want. But keep things simple. Thinking too much and overreacting will end up over-treating patients that otherwise will probably be okay on the floor. So thank you very much, and I look forward to discussing further this topic in the panel discussion.
Thank you. Thank you, Joanne. That was great. Especially love your last bullet point. So now it's my pleasure to introduce our next speaker, Dr. Christopher Knott Craig. He is a professor of surgery as well as the chief of pediatric cardiovascular surgery at Le Bonheur. He also holds the Susan and Alan Graff Endowed Chair of Excellence in Pediatric Cardiac Surgery. He'll be speaking to us about neonatal surgical management of Ebstein's anomaly.
Good morning, everyone. I appreciate the opportunity and the invitation to come and join our friends, Jose and Luciana de Silva and Jackie Kreutzer, a lot of friends that I haven't seen for ages, Norm Silverman. So I'm going to talk to you about the biventricular repair of neonatal Ebstein's, and it's going to be a very personalized talk, so humor me as I go through.
Use the red mouse to scroll on the screen.
Got it. So as we know, neonates diagnosed in the neonatal period with Ebstein's, about 1/3 of them don't survive the neonatal period. Everybody knows the neonates with Ebstein's anomaly. All the pictures that I'm showing you are actually patients that I've operated on, and this is one of them. Dr. Silverman mentioned the Salamayer score. David was at Great Ormond Street, and so we coined the term Great Ormond Street Echo Score, or the GO score, which has been pretty much universally accepted. And as you can see, those with grade 3 GO score who are cyanotic have a 100% mortality, and those with grade 4 have a 100% mortality during the neonatal period. And these are the patients that we as pediatric cardiac surgeons are most often presented with. So my approach to the symptomatic neonate and young infant with Ebstein is that I believe that about 25% of them can be managed medically. 90% of those needing a surgical intervention, in my experience, have undergone a biventricular repair. The Sebening stitch, approximating the anterior papillary muscle to the septum, is very helpful in making the valve competent. And we have a very liberal use of the bidirectional Glenn in the slightly older child, obviously not the neonate. And we've changed our management of those with anatomical polyatresia, where we did transannular patches initially, and we've converted and we put a small right ventricular to pulmonary artery conduit in those patients, but we primarily do biventricular repair on all the kids that we are presented with. And at the same time, we repair all the associated cardiac defects. This is a paper that we published several years ago, which again shows in the highlighted portion that the mortality or the survival was 94% in our patient population, and a biventricular repair was achieved in over 90% of these patients. The technique of the repair, it's incorrectly termed a monocusp repair. It, in fact, is what I like to term a cone repair, a De Silva cone repair without cutting the leaflets. So it's essentially a bi-leaflet repair with the anterior and the septal leaflets working. And if the anterior leaflet is very displaced and dysplastic, and the posterior leaflet is adequate, we would then do a de Vega annuloplasty with a Sebening stitch. And if we really feel that the tricuspid valve is not repairable, we use an inverted aortic bioprosthesis, and we believe that this is probably superior to the Stan's single ventricle palliation. Tarek and Norm Silverman very nicely showed the orientation of the inlet of the tricuspid valve in Ebstein's anomaly, where in the X, it's normally oriented to the apex of the right ventricle, but as the severity of the tricuspid of the Ebstein's anomaly becomes worse, the orientation becomes further and further towards the right ventricular outflow tract. The monocusp repair is really simple. It takes essentially 5 minutes to do. And what we do is we place a pligated suture at the junction of the anterior and inferior leaflet at that commissure, and we bring the suture out through a pledget in the medial wall of the coronary sinus, and basically create a bicuspid repair without cutting the leaflets at all. What that does is it brings the anterior leaflet all the way down to the septal leaflet. We then close the inferior of the two double orifice, because it creates a double orifice tricuspid valve, and we close the inferior aspect of it with plication, and that creates a mostly competent tricuspid valve, and then we do a fenestrated closure of the atrial septal defect. So the question is begged, are all neonates with Ebstein's anomaly candidates for biventricular repair? And I want to show you that, and make an argument that yes, they are. So the simplified biventricular repair can be converted to a standard De Silva cone repair. I know it's so because I've sent my patients to Jose and Luciana De Silva 3 or 4 years after doing a neonatal repair. Can the Stange repair be converted to a cone biventricular repair? Absolutely. How do I know? I did it in 2000, but I also sent my patients to Jose and Luciana, and they converted a Stange repair to a biventricular repair. I have, if there's time, and the moderator agrees, I have actually the video of the initial repair of this patient, which I can show you at the end of the presentation if you like. Tricuspid valve replacement can be converted to a cone repair. I know it's true because I've sent my patients to Jose and Luciana De Silva, and they've taken the tricuspid prosthesis out and converted the patient to a biventricular repair. And can tricuspid valve replacement be replaced after a neonatal tricuspid valve repair? Absolutely. I've done it several times. I'm showing you some of the patients that I've actually operated on. Norm Silverman showed LV non-compaction. This is a child that was evaluated by 3 programs in the Northeast, very prominent programs. Oops. Can you go back? Okay. So this is a patient, as you can see, severe LV non-compaction with a VSD and 20% ejection fraction on 4 cardiac medications that was transferred by flight to us in Memphis. This shows you a very dysfunctional left ventricle. In the evaluation, this patient was evaluated for transplant, but they thought he wouldn't survive long enough to be transplanted, and we repaired the patient. And this is the patient 2 years later. He had a 2-year-old birthday in November, and this is what his heart looks like. He's on no medications, and he's thriving. But should he require a re-operation later down, I will send him to Jose and Luciana De Silva because they do a much better job than I do as far as that's concerned. This is a patient that was transferred from San Antonio with functional pulmonary atresia and pulmonary valve stenosis. And this is the echo after doing an open pulmonary valvotomy and a biventricular repair as a critically ill neonate on a ventilator. Circular shunt. Circular shunts come in 3 different degrees. You have a mild circular shunt, which is almost part and parcel of patients with a poorly functional right ventricle, and you have those with moderate pulmonary regurgitation, and then you get patients with severe pulmonary regurgitation who need a critical intervention within the first few hours of life. This represents one of them. This patient had surgery at 4 hours of life, was taken from the neonatal suite, transferred to our hospital, and went straight to the operating room without a full echocardiogram. My problem, and this patient had ligation of the main pulmonary artery, bilateral pulmonary artery bands, and we maintained the pulmonary circulation through the ductus. She needed some LVAD support, just a cannula in the aorta and the right atrium without an oxygenator. And then we took the patient and did a stance repair 2 or 3 days later. But the problem when you ligate the main pulmonary artery or do a stance with a good right ventricle is that you create left ventricular dynamic outflow tract obstruction, which can be difficult to manage and would require usually esmolol infusions, digoxin and various other medications before you can go and then finally repair the patient. So most people that do biventricular repairs get shy away from it, and the reason is the intensivists get in the way of the patient recovering. So this is what the patient looks like when they come out of the operating room after biventricular repair. Central venous pressure is low, blood pressure is good, saturations are 91%. Post-op day 1, everybody's screaming, you have to take the patient back to the operating room, saturations are 65%. All you have to do is wait, because you get this reflex raise in the pulmonary vascular resistance, which you need to be patient to allow to recover. That's post-op day 1. This is post-op day 3. Saturations are a little better. Central venous pressure is still elevated. But by post-op day 5, the patient is fully saturated and recovering well and usually gets extubated a day or 2 afterwards. That's the fundamental lesson that we need to educate our intensivists about. You have to be patient when you do a biventricular repair on a neonate. So our experience with neonates and young infants with Ebstein's now exceeds 70 patients, but I'm going to show you our initial results. About 20 of these patients managed medically. 9 of them failed medical management and were treated in infancy, and all of those patients have survived. The neonatal surgical repair at the time was 32 patients. It's now over 43 patients. A single ventricle was done in 4 of them, or about 10%, and 75% of these are alive. Complete repair was done in almost 90% of these patients. If they had no anatomical pulmonary atresia, the survival was 91% in our experience. Those with pulmonary atresia, the results were significantly poorer until we started using a right ventricular to pulmonary artery valve conduit, and since then our outcomes are almost 90%. This is a patient that had the first stance operation converted to a biventricular repair. She was transferred by flight from Oxner Clinic as a 2-month-old ventilator-dependent, inotrope-dependent infant. Arrived on Friday night, we took her to the operating room and spent 11 hours receptating the heart and doing a biventricular repair. We put 2 valves in, one in the tricuspid position and one in the pulmonary position. And this is her graduating from kindergarten. She's now 23 years old, fully functional, fully working full-time, and is starting a family. This is the second patient that we operated on in 1994 with a circular shunt. She went to the operating room at 2 days of birth with severe renal failure, severe hepatic failure, cardiogenic shock. We did a 2-ventricle repair on her, and this is her 29 years later, about 1 month ago, with a family, fully employed, and with a young baby. And this is the patient well known to Jose and Luciana de Silva, and if there's time I can show you the actual video of this surgery. This is a patient who was transferred to us from San Antonio at just under 4 months of age, had a cone repair and a bidirectional glen. The patient distended the right ventricle atrialized portion, distended severely 36 hours after surgery, went on to ECMO. I took her back to the operating room and left the cone repair in place, but converted the patient to a stance with a bidirectional glen. And then 3.5 years later, I sent it to Jose and Luciana de Silva, and they converted the patient back to a cone repair, and this is the child 7 years of age. This is the very first patient I operated on, neonate with Ebstein's anomaly and a VSD. And this is his echo 20 years after his biventricular repair as a neonate. He went to college. He was a running back of the college high school team. He's fully functional on no medications, and again, he's now 29 years old. And these are the first 6 patients that I operated on in 1994. It's interesting. I waited 5 years before publishing these patients because I needed to have 5-year follow-up before I was able to say that this was a viable and a good option. Right in the middle of my lap is the little child that had the stance conversion to a biventricular repair. The girl with the sitting right on my left with a big smile, she's the one who's 29 years old with a little baby right now. And the one on my left, the little Indian boy, he's the patient who was the first neonatal Ebstein repair. How are we doing for time? Do we have time? We have 5 minutes? Okay. So this is one of the actual surgeries that we did. This is the patient's preoperative X-ray. Patient with pulmonatresia, severe Ebstein, torrential tricuspid regurg, as you can expect. Notice the very hypertrophied coronaries crossing the AV groove, consistent with severe Ebstein in the neonate. You need to put a suture in the right atrial appendage to get access to the aorta, and then once you've got the heart decompressed, you can convert to bicable cannulation. This is the valve. In this case, the anterior leaflet had linear attachments to the free wall of the right ventricle, but the posterior leaflet was actually quite nicely developed, which is unusual. In this case, we used a Sebening stitch to bring the free wall of the right ventricle to the septum. And you can see there's wide open tricuspid regurgitation. You also notice that the anterior leaflet is displaced into the right ventricle, which is an unusual form of Ebstein's. Here we are elongating the anterior papillary muscle to allow more distance for the anterior leaflet to approximate the septum in repair. We don't cut on any of the leaflets. I think it's important not to cut the leaflets in a neonate, but we just elongate the anterior papillary muscle. This is part of our Sebening stitch. It's a horizontal mattress pleated suture from the anterior papillary muscle to the interventricular septum. And here we're doing a de Vega annuloplasty because we don't want to trash the inferior leaflet of the tricuspid valve. We use a Hagar and we try and reduce the annular size from usually 26, 27 millimeters down to around 10 or 11 or 12 millimeters in size. And the valve, as you can see, is very nicely competent. Fenestrated ASD patch closure. Again, the concept for the surgeons is that if you make the tricuspid valve annulus small enough, you have tricuspid atresia. You don't want to make it that small. You just want to make it much smaller than it was, and then it usually becomes very nicely competent. Do aggressive reduction, right atrioplasty. And we do a non-thrombogenic closure of the atrium, which is a horizontal mattress running suture, followed by a over and over whip stitch. And then because the main pulmonary artery was a decent size and we've got a good tricuspid valve repair, we're doing a transannular patch. You can move that on to the next slide if you don't mind. And this child obviously did fine. So our current expectations for biventricular repair is that there should be a 10% or less mortality early and late, no different from that of older children. There's a low need for reintervention over 10 to 20 years, and the patients have the advantage of a biventricular physiology from birth. Interestingly, none of the patients that we did biventricular repair on have arrhythmias postoperatively. I believe that the arrhythmias are part of long-standing severe tricuspid regurgitation, and I think tricuspid valve replacement is probably a better option than the Stans operation in the majority of patients. And a parting vignette for those in the audience is, behold the turtle. He makes progress only when he sticks his neck out. Thank you very much.
Thank you very much. It's always a treat to watch those surgical videos. They were amazing. That was amazing. Thank you. So next, it is my pleasure to invite our next speaker, Dr. Adam Christopher, up to speak to us. He's an assistant professor of pediatrics at UPMC Children's Hospital of Pittsburgh, and he'll be speaking to us about imaging in the interstage treatment of Ebstein's anomaly.
Thank you, Laura, and thanks to the organizers for the invitation to speak today. It's my challenge and privilege to talk about this unique anatomy and physiology that we're terming interstage Ebstein anomaly, which, as has been discussed in many centers and historically, would have meant on the road to single ventricle palliation, but of course is not the path we'll see today. So just briefly, we're going to cover that interstage anatomy and physiology that has already been discussed. And then we'll discuss how, if this can progress here, the non-invasive techniques, including echo, as well as cardiac MRI, can really help us understand both the anatomy, the native morphology of the tricuspid valve as it relates to candidacy for the De Silva cone operation, as well as some of the other functional parameters that really help in candidacy assessment. So as my colleagues have done, I think what better way to move through this material but to follow up one particular case. And we'll start with the very first chest x-ray at birth for this newborn who had had a fetal diagnosis. And I believe actually Dr. Weinberg had shown some fetal images of this baby of severe Ebstein anomaly with associated pulmonary atresia. So we can see, of course, the wall-to-wall heart, as has been shown so many times today on the chest x-ray here on the left, as well as the transthoracic echocardiogram from day of life 1. And it's always impressive to us imagers when your sector needs 9 centimeters of depth just to incorporate the entire heart. But I left, in particular, the diameter of the chest and of the cardiac silhouette here because I thought it was particularly interesting to kind of rotate and overlay this echocardiogram of the same dimension and give kind of perspective of what we're seeing when we see that x-ray. So much of that silhouette is the right atrium. And of course, as we heard from our CSU colleagues, there are so many associated impingements related to the size of this heart. So with a severe cardiomegaly, of course, we have that respiratory compromise as well as underdevelopment of the lungs. And in this case, in the setting of pulmonary atresia and an obligate right to left shunt, there was severe hypoxemia, as well as decreased cardiac output. So there was multiple mentions already of, the compromise of left ventricular filling as well as cardiac output. Therefore, in this case, resulting in acidosis. And so this patient underwent within the first 36 hours of life a Starnes right ventricular exclusion procedure, as well as significant right atrial reduction with a BTT shunt placed for pulmonary blood flow. You can see this x-ray. This was post-op at 1 week of life with already significant improvement in the aeration of the right lung related to that right atrial reduction. And the transthoracic echocardiogram at this time, of course, shows that two-fro flow through the Starnes patch. And you can see significant reduction in the right ventricular volume, as well as with improved left ventricular filling and function. So let's just briefly then pause and kind of focus on this anatomy, which I think is so pivotal to us imagers to know what to expect and what to look for when we're looking at these postoperative images. So I pulled this nice diagram from Dr. Starnes' series. This is circa 2006. And in it, he highlighted kind of the two main take-homes for the Starnes procedure over his first decade or so of doing it. One was that initially they had been excluding the coronary sinus into the right ventricle as well, and they quickly realized that it was important to keep the CS above the patch. But then also importantly, in this particular paper of the first of this series of 16 patients, it became very clear that non-fenestrated patches had a significantly decreased survival associated. And so, of course, that's where this 4 millimeter fenestration support comes from. Let's continue on. I thought this quote from this paper in 2006 is particularly interesting, relevant to the discussion today, that, quote, the downside of right ventricular exclusion procedure is commitment to a single ventricle Fontan pathway, which of course, as we heard from Dr. Knott-Craig and others, is just not the case. And so just briefly following this patient, this baby, of course, had severe cyanosis at birth, and this is an actual plot of her saturation over the first 3 months of life. She had the BTT shunt placed with incredible improvement in her oxygen saturation, and then that saturation drifted down over the first 3 months of life, and at which time there was conversation of, what's our next step? And I think the most common pathway at this point, and what ended up being her pathway, was a bidirectional Glenn procedure. But I'll just point out that there was discussion at the time of whether this patient could proceed to a Starnes takedown and De Silva cone operation at that time. Some of the particular parameters that were helpful in making that decision were related to the imaging, not only of the right ventricular function, which, as was discussed, is hard to assess, in particular after exclusion with a Starnes patch related to that limited preload. But also, this patient had pulmonary atresia and associated small pulmonary arteries. So the thought was, with Glenn to support pulmonary blood flow for foreseeable, months to years, the patient could continue to grow, develop pulmonary arteries, and then we could reassess candidacy for the cone at that time. So fast forward, the patient's now 2.5 years of age, doing fairly well, but still with her Glenn and Starnes patch. And as you heard from Dr. Al-Said before, we rely fairly heavily on cardiac MRI to augment our understanding of both the anatomy and physiology of these patients. And so this is a sedated cardiac MRI in this 2.5-year-old. You can see on this short axis image on the left, we're seeing the mitral valve en face and the left atrial appendage, as well as somewhat surprisingly, even under the Starnes patch, we could appreciate a lot of the tricuspid valve tissues. In this patient, there's actually less severe rotation despite the very severe initial neonatal presentation. And so we can actually see elements of all three of the leaflets in motion underneath the patch. And then again, as Dr. Al-Said showed you before, we typically acquire that axial or four-chamber stack of the heart to be able to better assess some of those attachments that Dr. Silverman had alluded to, both linear, hyphenated, and focal attachments to some of these leaflets. I'll show you on some of the subsequent images. We did give contrast to this baby, this 2.5-year-old, at the time of this study, both to assess the intracardiac anatomy as well as the vascular anatomy, which becomes so relevant as we're entertaining future procedures. You can see here on the left-sided image the bidirectional glen, as well as some hypoplasia of that central pulmonary artery, which is seen on the volume rendering and to the right as well. And here I just wanted to highlight one of the common surgical questions as we're entertaining a biventricular or 1.5 repair, is the positioning and distance of either an atretic pulmonary route, main pulmonary artery, to the right ventricular outflow tract, whether it was that way from the get-go or was surgically ligated. Important to the surgeons to know that distance. So here's a kind of a time to break and ask what imaging markers actually matter at this stage, especially as we're considering candidacy for the De Silva cone operation. And this was a nice summary just put out in the last year by our group, looking at the first 6 patients that went through the program here for Starnes takedown and progressed to 1.5 or 2 ventricle circulation. In that paper, we summarize some of the imaging factors that we certainly note, but are still in the process, I think, of understanding what is most important when it comes to candidacy. And these include the angle of the tricuspid valve rotation, as we've seen, and I think Dr. Silverman nicely showed us, can be highly variable. But certainly the further it is into the right ventricular outflow tract, the more complex the repair may be. And then I won't go through all of them, but there are many images we look at. So we'll go back even for this 2.5, 3-year-old to the fetal imaging that Dr. Weinberg showed us often has some of the best resolution for some of these subtle valve attachments. To the fetal imaging, to the initial neonatal studies, as well as even TEEs from the Starnes procedure itself, can really be helpful. So you can see on this short axis view here, this redundant sail-like anterior leaflet that does have some focal attachments to the free wall. In this case, a septal leaflet that's not dramatically displaced, but certainly limited in its mobility. And in this case, there's a gap between that septal leaflet and the inferior leaflet down here. I'll just note that, and we'll discuss again, the Starnes regurgitant jet velocity is noted in some of the literature about being an important metric. And we honestly debate in our surgical conference about the importance of that metric in deciding whether a right ventricle can be a good candidate for biventricular repair. Certainly it gives you an assessment of pressure generated by that right ventricle, but it can be very variable in terms of both the function of the right ventricle and the patency of the right ventricular outflow tract. So in this case, there was pulmonary atresia. And we've certainly found that gradient does not end up being decisive in terms of candidacy for the cone. So this is just the table from that paper summarizing the specifics of those tricuspid valve morphologies in these 6 patients. And I think really the take home here is that it was highly variable. We had all different kinds of attachments, various degrees of displacement or hypoplasia of some of the leaflets. And of course, all of these patients went on to successful De Silva cone. And we don't need to necessarily review kind of each of these different patients, but just some examples of other focal attachments. And in some cases, especially for outside patients that may only have a single modality come along with them, again, we can use nice temporal resolution on cardiac MRI to assess some of these leaflets and their attachments. So let's continue here. Our case continued. So that 2.5-year-old, after the MRI as well as cardiac catheterization at that time, was deemed a good candidate for Starnes takedown and De Silva cone operation, which she underwent successfully, along with a transannular PA-plasty that extended out into the pulmonary arteries that were hypoplastic, with a monocusped pulmonary valve placed at the time, as well as fenestrated ASD closure. So this was just the initial postoperative transthoracic imaging, where you can appreciate the cone here with just trivial tricuspid regurgitation, and the mean gradient here was 3 across the tricuspid valve. Here's a subsequent cardiac MRI. You can see that the Glen was left in place at the time, and so this patient has an effective 1.5 repair. Again, you can see the cone in the center here functioning quite nicely, and outflow through that right ventricular outflow tract. I just want to highlight, I mentioned that, you know, we don't always have, we know we don't have all the answers when it comes to imaging. And so here, briefly wanted to show some data courtesy of my colleague, Dr. David Little, who's focused not just on the right ventricular size and function, as we often so are, but on the mass of the right ventricle. And so here he carefully contoured out the epicardium of the right ventricle to give us an indexed RV mass. And the nice thing about this metric is that it's independent of the volume, right? So many would argue the right ventricular volume and function may not mean a whole lot in the setting of a Starnes patch, but the mass is the mass, regardless of whether you've excluded the right ventricle. And so he nicely showed in this data that also was recently presented at the Society of Cardiac MRI that the indexed right ventricular mass in this multivariable assessment could predict need for Glen, as well as low oxygen saturation following the cone. And so the key is that this was independent of right ventricular size. And so lower RV mass would portend worse outcome, whereas more mass obviously would be a benefit. So then just briefly, case conclusion for our now 6-year-old who's clinically well running around attending kindergarten. This is her most recent echo from just last month, where you continue to see beautiful competence of this tricuspid valve with just trivial regurgitation. She does have some significant regurgitation at the pulmonary valve now, and so the right ventricle is a bit dilated, but you can see the right ventricular function is excellent. She has had a couple trips to the cath lab as well to address her pulmonary arterial hypoplasia. She has stents in the pulmonary arteries, and you can see flow again in the conduit here, or sorry, in the opened outflow tract and into those hypoplastic branch pulmonary arteries. Just briefly, just to prove we do, put a lot of stock into our cardiac MRIs and continue to follow this girl, mostly to help in the decision-making process of whether that Glen can be taken down. And she's certainly made a lot of progress in terms of right ventricular function normalizing. You can see in this central short axis cine, the cone on FOS that again is coacting very nicely, and that patent right ventricular outflow tract. Just one brief plug for 4-dimensional flow, as Dr. Al-Said showed earlier. This allowed us to not only quantify the degree of tricuspid regurgitation here, which is only mild, but also the ASD, that fenestrated ASD shunt that's residual, and of course, all the other relevant flows in the PAs and in the RVOT relevant to this 1.5 repair. So, in summary, this interstage Ebstein anomaly is a unique physiology that certainly, as we've seen, can frequently transition to the 1.5 or 2 ventricle repair. And multimodality imaging, including echo, MRI, and others, can really help us assess for these important markers that can determine candidacy for the cone. Thank you.
Thanks, Adam. That was terrific. Tarek mentioned in the chat, and I'll mention to everyone listening, we've got some really thoughtful questions coming through. I'm sure there are more out there, so just pop them in the chat and we'll have a panel discussion after our next speaker. So now it is my honor to introduce Dr. Luciana de Fonseca de Silva. She's one of the directors of today's course. She's an assistant professor of surgery here at University of Pittsburgh, Children's Hospital, Pittsburgh. And she will be talking to us about cone after Starnes.
Thank you, everybody that's online or here presentially, and thank you, Dr. Craig and Dr. Norman Silverman for coming and deliver excellent talks and with excellent results. I have no disclosures. And those are pictures of Dr. José da Silva, Dr. Morel, Dr. Jacques Kreutzer, Erin Colvin, and all the amazing members of the Heart Institute at the UPMC that day by day manage to gather the Ebstein anomaly patients with enthusiasm, achieving excellent results. Thank you, everybody. Neonatal Ebstein's anomaly is a challenging situation with elevated mortality risk. This study using STS database demonstrated an overall mortality of 27.4% for those newborns that required any type of surgical intervention. Also, there were only 3 neonates in average operated in each center during a 6-year period, reminding us how rare is this situation. In Ebstein's anomaly, there is also a great variability of anatomical presentation. Some of them, like the double orifice at the left image and the severely rotated valve at the right, requiring more complex maneuvers during the cone repair. In our hands, all those complex anatomical presentations can be repaired with the cone procedure in children and adults, with some technical improvements done after the first publication in 2024. In newborns, Dr. Not Craig, with a monocusp technique, achieves great results with early repair, as he previously demonstrated. In our experience, when the patient presents favorable anatomy and reliable RV function, it's possible to do the cone repair. And in 2014, we presented in AATS meeting 5 cases operated in São Paulo. We demonstrated that the repair worked well in neonates and the heart progressively decreased in size, as we can see in the radiographic evolution. However, the valvular tissue in newborns is very delicate, and in presence of complex anatomy, the surgical procedure is prolonged. For that reason, we recommend the cone repair in newborns only in selected cases with favorable anatomy and preserved RV function, as I mentioned before. When we receive a newborn with Ebstein's anomaly, we need to be prepared for all the possible situations, as Dr. Joan Sanchez mentioned, including ECMO support, PDA closure, heart catheterization, and surgical intervention. However, many newborns with Ebstein's anomaly will not require any surgical intervention during the neonatal period. The team needs to keep vigilant, treat the cyanosis and the heart failure as needed, but trying to avoid intervention. The treatment must be individualized for the patient and for the institution. Any institution has their own surgeons with a good or a bad experience. In very sick newborns with Ebstein anomaly and complex valves, or those on ECMO, the STARS procedure is a less complex and well-established procedure. It decreases the impingement of the ventricular septum over the left ventricle and immediately creates more space for the lungs. However, the STARS procedure would commit the patient to single ventricle pathway with all the long-term complications. So bearing in mind that the right ventricle would undergo progressive involution, José Pedro and I reasoned that the right ventricle could be rehabilitated to work as a pump if we perform a cone repair. So in 2019, we performed the first case of biventricular repair after STARS with the cone procedure and published it in 2020. The pulmonary valve was also reconstructed in those 2 initial cases. And even in circular shunt patients, after initial Starnes procedure, it's possible to achieve biventricular repair, as demonstrated in this other paper. 2 cases with circular shunt were operated immediately after birth in Brazil by Dr. Freire, and later Dr. José da Silva performed biventricular repair at 5 months and 6 months of age. Here in Pittsburgh, we had 3 cases with neonatal circular shunt, 2 first operated in other institutions and sent to us, to a later submission to the cone repair. Here we see a surgical moving showing the details of the repair. So the patch is carefully removed to avoid damage to the leaflets that we can see underneath. And the patch that we use we recommend for the Starnes is a PTFE patch to avoid adhesions to the subvalvular apparatus. And then we see the valve underneath, and then we do the cone in a usual way. This is the result of that operation. The initial small pulmonary valve is now enlarged with excellent tricuspid valve and pulmonary valve function. We usually recommend the Glenn if there is pulmonary atresia before the cone procedure, but in this patient with pulmonary venous stenosis and tracheal malacia, she was not a good candidate for a Glenn. Since her RV systolic function was adequate, we proceeded with the cone repair and pulmonary valvuloplasty, achieving a good biventricular repair. Last year, Dr. Dobson and our team published the results with the first 6 patients operated in Pittsburgh with the cone repair after Starnes. Now we have 13 patients, 2 of them were operated in Tampa. We received 14 patients referred for a Starnes, and 1 of them is still waiting after the Glenn. So we had 5 patients with pulmonary atresia, 3 with circular shunt, as I mentioned before, 4 patients with normal pulmonary valve, and 1 patient with pulmonary valve stenosis and associated VSD. This patient was operated in Poland and come to Pittsburgh for a biventricular repair. So we achieved biventricular repair in 4 patients until now. So as I mentioned, we had 13 cone repairs after initial Starnes in the United States, and the youngest one is 5 months and the oldest 5 years of age. Another patient has a Glenn and is waiting for a possible Starnes. We applied septal leaflet augmentation in 9 patients, and the discharge echo presented excellent tricuspid valve repair with trivial or mild regurgitation in all. And 2 patients persisted with right ventricular dysfunction. Here we have one of the challenge cases that we received. This patient was submitted first to a stent in the PDA, later Starnes and Glenn in another institution, but the Glenn failed, and so she needed a Glenn takedown and a BT shunt. She had some neurological injury, she had a tracheostomy, she came to us, and we did a cone repair, and the result was really good. Regarding RV dysfunction, we can still perform the cone in patients with severe RV dysfunction if we have a mature Glenn to guarantee the cardiac output, like this patient here. So now we have, in the mean follow-up of 30 months, we have 12 patients that are doing clinically really well with no need for tricuspid reintervention. There was one non-cardiac death at home 3 months after the cone in a patient that was waiting for a liver transplant. We did the stars to try to make conditions for her to be submitted to the liver transplant. She had the previous tracheostomy and neurological impairment from previous operations. And she passed away at home due to complications of her tracheostomy 3 months later. We have trivial tricuspid valve regurgitation in 6 patients, mild tricuspid valve regurgitation in another 6, and normal RV function in 10, one with moderate dysfunction, and there are 2 patients still with severe dysfunction, but actually doing clinically really well with associated gland anastomosis. So in conclusion, the STARS procedure is easily reproducible, ameliorated LV morphology and function. The right ventricle rehabilitation after the STARS procedure is feasible with cone repair and presents good initial results. The low systolic RV pressure estimated by the regurgitant jet in the STARS orifice did not contraindicate the STARS, the RV rehabilitation with cone repair in our experience. And in critical newborns with Ebstein's anomaly, the feasibility of later RV rehabilitation favors the staged repair over the neonatal two-ventricle repair in our experience. Thank you so much.
Thank you. That was incredible. Just incredible data, incredible results, and incredible work. So now I'd like to invite all of the speakers who were in this section. In addition, Dr. Craig Dobson, our Director of Clinical Operations, will be joining us on the stage for a panel discussion. We've got quite a few questions in the chat. So if you could pop up maybe, I'm hoping, is Joanne, are you still able to hear us?
Yes, and the camera is working.
Great, fantastic. So while people are assembling here, I'm going to put you in the hot seat. We had a question regarding kind of how you guide your decisions of how to and which inotropes you may or may not use when you're trying to treat low cardiac output syndrome in neonates with Ebstein's. And then sub-question, do you use any imaging parameters to guide your decisions?
Well, this is an important question. And if you notice, I didn't want to go specifically on which ones to use because there is as many choices as cooks exist in this world. So I think that it's about physiology and understanding what the problem is, understanding what are the side and the collateral effects of each inotrope and what we want to achieve. So we want to achieve pulmonary flow. We want to decrease pulmonary vascular resistance. So ideally, milrinone would give us inotropy and lusotropy and vasodilatory effect. And for inotropy effect supporting the left cardiac output, we typically use a little bit of epinephrine. I want to reinforce the fact that the most important thing is to promote venous return, but not to increase volume overload. So those drugs that will favor pulmonary venous return without increasing pulmonary vascular resistance are especially indicated in those patients. So for instance, vasopressin, which will give us vasoconstriction, venous constriction, and will decrease PVR. So again, there is no one single choice. You have to stick with what you have and get back to the physiology.
Yeah, absolutely. Thank you for that really thoughtful answer. So next, we have a question from the chat regarding when you have assessed a severe circular shunt and the team has made the decision to stop prostaglandin to restrict the ductus, this person asked, do we care about anterior flow in the case of functional pulmonary atresia or pulmonary stenosis? Maybe you could talk about pulmonary development and if this is a consideration. The downsides of stopping PGE in this case. I don't know if Dr. Craig wants to comment on.
So, can I answer the previous question first?
Yeah, sure.
So, my go-to drugs after neonatal Ebstein repair is medical volume resuscitation, which is a synonym for vasopressin. It achieves exactly the same thing. And so I agree with the intensivist. So low-dose epinephrine, 0.03 max, associated with vasopressin. I think those are your go-to drugs in the neonatal Ebstein patient. And then in terms of stopping prostaglandins, I think it's got to be done in a controlled situation. The patient's got to be in a cardiovascular intensive care unit.
Yeah.
And then you need to clearly state what your threshold is to restart the prostaglandins. And for someone who's on positive pressure ventilation, in our experience, that would be 78%. Saturations are better than 78%. You can assist with stopping the prostaglandins and looking and seeing how the ductus closes and whether there's initiation of prograde pulmonary blood flow.
Great, thank you. So another question that's come up. So now this is a question for Dr. De Silva or Dr. Craig. In a patient where you are placing a bidirectional Glenn with this physiology, how important is pulmonary regurgitation, and what, if anything, are you doing to address pulmonary regurgitation at the time?
Yes, well, we had bad experience in two cases, actually. One came from outside, because people use a Glenn procedure and dilated the ventricle and after the cone. The cone procedure was very nice, but despite of that, the heart was still dilating progressively. And that was because of pulmonary regurg. That was become more severe because of dilation of the outflow tract and functional regurgitation. So if you have pulmonary regurgitation, it's better, except if you have a small ventricle, of course, in hypertrophy, small ventricle in general, well functioning, you have to take good care of the pulmonary regurgitation. Otherwise, you have some risk of the gland does not work well because you have more regurgitation diastole because the blood is flowing in the gland and systole and diastole. So that may overload the RV a little more, get a higher pressure and diastolic pressure for the RV. So I recommend to take care of the pulmonary valve at the time of doing the Glenn.
At the time, thank you. There's a question I'll ask several of you to weigh in on. This is a good question. So the question is, are there any parameters that would deem biventricular conversion with a De Silva cone procedure prohibitive or high risk? And then I'll also put out there, are there features that you like to see as well? And these could be imaging features or clinical features.
So some centers, they are considering the velocity in the stance orifice to indicate or not the conversion to biventricular repair. And our experience that the velocity makes no sense to contraindicate the procedure because the filling of the heart is not enough. And we are doing the cone in all patients, even if we have a low pressure in the right ventricle. So that's one of the question, one of the issues that we are seeing in other presentations. Another thing is the function of the right ventricle. Sometimes it's very difficult to evaluate. Then we need to go back in the pre-Starnes function of the ventricle. We can evaluate the anatomy of the valve and the function of the ventricle itself before the Starnes to see, they have an idea what we can expect about the function of the right ventricle. We had two patients that they had severe RV dysfunction in the post-op, and those patients, they had a velocity in the stats less than 1.5 meters per second. So we don't have still a huge number of patients to say that that would be predictive of bad RV function in the post-operative period. But all those patients, even with bad ventricular function, they have a low pulmonary venous central pressure. So that will be more beneficial than a Fontan procedure in the long term, we imagine.
Well, those are outstanding points. Sorry, go ahead.
Go
ahead. I'll make one after you. Go ahead.
No, I want to clarify a question first, but I can do it after him.
So actually, I was just going to say that from the sort of clinical and imaging standpoint, I think the appearance of, when you look at a post-Starnes right ventricle, can frighten you off of the possibility of rehabilitating the ventricle. You certainly alluded to that, and we brought that up in the paper that we wrote. But all of us, I remember sitting in surgical conference going, one particular, that's not a very good one. We don't think we can do it. And several of us felt that way. I certainly said, I don't think this is a good idea. And you said, I want to try. And so that patient, I was on the ward as the attending the next day after that patient's procedure, and the toddler came bouncing up to the ward a day after a successful cone after Starnes, and I was floored. These patients, I think from an imaging standpoint, sometimes looking at an underfilled right ventricle that may not be squeezing, but may not be squeezing because it's not getting enough flow, it can be very daunting to realize that this actually is possible.
Oh, that's a great point. Go ahead.
Yes, I agree that in general there is some concern about that, but as we discussed, it's not possible to define it. I'm more concerned when the heart is dilated.
Okay.
Because if the heart is small, then you put more volume there, and the amount of volume of ejection is not, the blood ejected to the lung could be a little low, but then you have the chance to have a glen or even a shunt if you have a case of pulmonary vascular, elevated pulmonary vascular resistance, contraindicating a shunt. So we don't know for sure. And since we're at the beginning and you have a way out of it, which is getting new source for the blood, the lung perfusion, and wait for the heart to recover, I think that's why I think we can invest in that, and then we find out what was the best way to evaluate it preoperatively. But I want to take the opportunity to make a comment about Chris' presentation. We have been friends for a long time, but I didn't know his work as deep as he shows today. And I know that he has an excellent result with his primary repair, and we get the benefit of two ventricle repair from the beginning. But now the other, so is one thing. The other is that we have a rare disease. Many people never operate on Ebstein anomaly, never repaired. And when a newborn is decompensated in heart failure, is far away from the center, like here or his center, then we have a different problem. So nowadays, we are discussing that issue at the ATS group, a writing group, and part of that, Dr. Not Craig also part of that. So some of those issues are going to be resolved, but the tendency is to indicate in those the difficult case the Starn procedure, because I think it's easier to be done. And especially if you consider the case of pulmonary atresia, true pulmonary atresia, with no leaflet, there's just muscle or fibrous tissues. So in that case, I think it's much simpler to do the Starn for any surgeon that have a good experience doing congenital heart surgery. On the other hand, we cannot, the surgeon can do it well, primary repair, like we do with the cone in special condition, like he does in most of his cases. So they have to pursue that path too, and then at the end we can compare with larger numbers. Regarding doing this, the repair after the Starn, repair of the trachea valve, we were the first to bring up, to do it, but the concept was demonstrated by Dr. Craig when he replaced the trachea valve by a bioprosthesis in the patient who had the Starn before. So there are different things, but he proved that was possible to do. So he was the first to do that. I recognize it in my initial paper, even though I've been provoked because I didn't see that paper. I saw the paper, but the case was embedded in other cases, and I didn't see that. Maybe I had thought I had done it much earlier, the repair trachea after the Starn procedure. So I want to clarify that and say that his work is really excellent. I saw the repair he did. He's like a master doing an operation. And I think that can be performed in some patients because it's easier. And by our experience too is very good. We never had an issue with Ebstein Anomaly repair. All the patients survived. Yeah. Now with the technology that we have available. In Brazil, when we did primary repair, we had good results, but they were kind of selected patients, a little older, after 15 days of age, between 15 days and 30 days. We did the total of, when I was there, 10 cases. We lost 2 patients, and one of them was because of pulmonary bleeding. So it's not directly related to the operation, but because of AVMs. And the other one for heart failure, and we didn't have the option of ECMO at that time. So those
the cone, primary cone repair, neonatal Ebstein.
Repair, right? Yeah. But I understand that is possible if you have a lot of experience. If you want to do it in general, then I think the Starn procedure makes more sense.
Yeah. No, your comments are so appreciated, and it's such an important point. And I was really inspired watching your your pictures of all your patients, as well as the pictures of the intraoperative videos. I think it's just remarkable work, and it's great to have you both on the same stage to discuss your separate, slightly different, but also more similar than different perspectives, I think, on young babies with this condition. So I think that's great. Dr. Not-Craig, did you have any comments regarding that?
Yeah, South Africans, once you get them talking, you can't get them to shut up,
Okay, well, we do have a timer, sir.
Dr. Silverman is a good example of that.
Okay, do you have one comment then?
One comment.
Okay.
The problem with the neonatal Ebstein is that it's become fashionable to talk about the RVSP, or the right ventricular systolic pressure. But when the tricuspid valve is hugely dilated and there's absolutely no coaptation, the RV can't generate any pressure. So I think in my own experience, I don't look at the RV systolic pressure based on the tricuspid regurg. I just look at the RV function. If there's a reasonable right ventricle and a reasonable right ventricular function, I really think that those patients could be easily repaired in the neonatal period.
And that's a great comment and a great segue to our next question. And this is more for Dr. Christopher. When you think about RV size and RV function in the quote inner stage, how are you as an imager assessing these things? What tools are you using? What are you relying on? Echo, MR, et cetera?
That's a good question. And I think, as I alluded to, we don't have all the answers. And so that's one of the great benefits in having all these referrals so that we can really, gain numbers and knowledge about what parameters make the most difference here. I think, in summary, really taking multiple modalities and multiple measures into account is probably the most important. There isn't just one particular that, as we've heard, makes a patient not a candidate or a great candidate. But I think in specific to function analysis, certainly the cardiac MRI, I think as Dr. Al-Said discussed, is our best kind of most accurate quantitative measure of that. And so that has become our standard for preoperative candidacy.
Oh, that's great. And I think something I've always, working with you both, working with all of you up here, something that's been impressive to me is how much, Luciana and Jose, you asked to go back to the fetal images to understand the valve tissue and what the heart looked like in development. That's been really impressive to me. And Dr. Weinberg gave a great talk earlier today about that, but I didn't know if you wanted to comment about just the relative importance of the fetal and the early neonatal imaging in some of the decision to do cone after Starnes.
Yes, so every time that we are evaluating a patient for a cone after Starnes, we ask for the operative report, the previous one, when the patient is coming from outside, and the pre-Starnes images. One of the patients that we received, he did not have one because he was taken from the belly of the mom immediately to the operating room to do the Starnes in another center. So we asked for the fetal echo, and that fetal echo gave us the image that we need, and the valve looked like a little bit muscularized. And at the surgery, we found that was truly like more muscle than leaflets in some place of the valve, and we were still able to do the cone repair. So all the patients that we received to evaluate after Starnes, we were able to fix the valve until now. I would call attention for some patients that are waiting for a long time, and then they develop systemic pulmonary collaterals, and that make a little bit more difficult the operation itself, because we receive a lot of blood come in the left ventricle. That makes really difficult the operation. So those are the points that we really look for. And I like the idea of Dr. Not-Craig in some patients to place the prosthesis in the tricuspid position if the valve is very difficult to repair, but place the prosthesis there, but keeping the leaflets, especially in those newborns with a normal pulmonary valve, with a functional pulmonary atresia or normal pulmonary valve. So those patients can benefit from that technique. We did 3 cases of cone after tricuspid valve prosthesis, and the patient did really well. So this is another thing that we need to warn the surgeons. If they are doing a repair in the tricuspid valve, they are not able to fix the valve, please do not remove the leaflets. Keep the leaflets there. Make sure that they will not be obstructing the valve. Place a prosthesis, and later on, when the patient needs, we can try to fix the valve. And if your biventricular repair, the neonatal in 2020, she had a prosthesis and the leaflets are there, we can fix that too.
That's great. No, it's such an important message. Thank you, Luciana. That's great. One last question for the panel. We talked a little bit about, some of you touched a little bit about this in your talks about kind of the early age for when you would attempt a cone. We have a couple questions in the chat about how late might it be to do a cone. So cone at the time of a long time glen, maybe before a fontan, when clearly the RV has, remodeled and adapted to having a Starnes patch in for a long time. Is this something you've thought about or something that you can offer some insight into?
During the presentation this morning, Sarah Trucco called attention about the indication for ASD closure. I think those patients, if we have an indication for ASD closure, they need to come to the OR to do the repair like she mentioned before. And the reason for that is if we operate the patient at early age, during the growing process, there is a possibility that the growing process with the tricuspid valve in the right position, with the ventricle pumping against with a competent tricuspid valve, it can have a better function in the late term. But this is something that we still need to evaluate. And some patients with the tricuspid valve, Ebstein anomaly, they are feeling like well, but they cannot imagine how better they could be if they had the valve fixed. So it's a little bit tricky to evaluate the symptoms in patients with Ebstein's anomaly. And some of the adult patients that we operate here around 40 years of age, after the operation, one of the ladies told us, oh, if I know that was the real life, I would have operated much earlier. So this is something that we need to take in mind, and with the possibility to do the cone repair in almost 100% in our experience. We had just one patient that we need to replace the valve after the cone here. So I think we should indicate earlier, around 4 to 5 years of age, not to wait too long in those patients that has severe tricuspid regurgitation and dilated heart mainly.
Yeah, please. Do you have a final comment?
Do you want to know specifically about the cone after Starnes?
Yeah, that was part of the question, was cone after Starnes. Like what's the...
Yeah, that's
that was a great answer. We could talk all day.
That's a difficult question to answer right now. But for example, if you have a patient that's not doing so well with the fontan, and you have to take down the fontan, then there's a procedure that that we do it, not often, but we do it sometimes. And then if you have RV that can be recovered with the pulmonary valve, for example, or tricuspid valve, then we can do a bed 1.5 ventricle with a fenestration. So then we give time for the RV to recover, and at the beginning, we'll supply some blood to the lung. And you can even add a little shunt. You have already the gland. So, but we don't have experience to say that yet, but I think it's possible.
Yeah, something to look forward to. And Luciano, your answer was fantastic. It was a kind of a two-part question. So thank you very much. I think we're out of time. Thank you so much to our panel of speakers. This was a fantastic discussion. And as our panel exits the stage, I am going to introduce my colleague, Dr. Tariq Al-Said. Dr. Al-Said is an associate professor of pediatrics here at UPMC at Children's Hospital of Pittsburgh. He's one of my close colleagues in imaging, and he will be moderating the next session on cone repair in special situations.
Thank you so much, Dr. Olivieri. Thank you, everyone. These were really fantastic sessions. The next session is also a very exciting session. We're going to talk to Dr. Jose da Silva himself about some cone repairs in special situations and difficult cone repairs. Dr. da Silva needs no introduction. He is a professor of surgery at University of Pittsburgh and the director of our international da Silva Center of Ebstein's Anomaly. Along his multiple achievements, he and Dr. Luciano da Silva started the cone operation for the tricuspid valve in Ebstein's anomaly 31 years ago. Dr. da Silva is a great mentor and a friend. Welcome, Dr. da Silva.
Thank you, Dr. Tarek, for the kind introduction. I always thankful to Victor Morel and the UPMC for creating the Da Silva Center for Ebstein Anomaly. I want to thank also the organizer of this meeting, especially Kate Scollin, Drew Berkerhold, and Erin Colvin. I'm also grateful to Dr. Norman Silverman, Dr. Christopher Knott Craig, and Dr. Simone Pedra, who came from far away to enrich this symposium. Finally, I want to thank to everybody who are lecturing or attending to this symposium. I'm going to address the special situation in Ebstein anomaly and how to repair it. I call that those special situations. They have a hypoplastic tricus valve leaflet. We have tricus valve extreme rotation into the right ventricle outflow tract, and cone repair of tricus valve replacement, and also cone repair of the Stern procedure that I'm going to skip because it has been discussed already. Here we have in the left the Ebstein anomaly with displacement of septal and anterior leaflet, dividing the ventricle in two cavities, atrialized and functional RV. And in the right, we have the cone procedure, where we mobilize all the abnormal leaflet attachments, leaving only the apical, the area, a small area near the apex of the heart without cutting the tissues, the subvalvular attachment, and then make a cone and place it in the right AV junction. Here we have a real case. The septal leaflet is very small. We mobilize the anterior leaflet, connect to the inferior leaflet, then we make an anteroseptal incision and mobilize the septal leaflet together, in this case, with the anterior leaflet. Then we rotate the inferior leaflet to augment the septal leaflet and make a cone. Then we placate the annulus accordingly, and we have in the right a good cone repair. Here's another case where we combine again the inferior leaflet with the septal leaflet and got an excellent repair. Then this is a patient, first adult patient, one of the adult patients from this institution, where you see that the anterior leaflet had like a normal attachment to the RV. The inferior leaflet was tethered, but was okay. And then we could mobilize them and do a cone, which became completely competent and with good distal attachment and good structure for the right ventricle. So the echo shows that the RV is good with good subvalvular apparatus, with good trabeculation of the wall and good function. So even though this lady was older, she had symptoms because there was a very severe regurgitation, but she has a good structure RV and to have a good long-term result. Now we have this patient which echocardiogram shows little leaflet, almost no leaflet when you see in four-chamber views. probably certainly the leaflet were positioned in the outflow tract of the right ventricle. And this will certainly require enlargement. See here the severe regurgitation, and this probably require enlargement of the leaflet. And so this is the operation, and here, after we did all the lamination of the valve, start constructing the cone, we noticed that we're missing some tissue here near the septal area. So we got a fresh autologous pericardial patch and used it to augment the septal leaflet, avoiding avoid tricus valve stenosis and distortion of the cone at the end. And here we have the echocardiogram. Look, there's some prolapse of the leaflet, but the coaptation area is distal, so that does not affect the competency of the valve after the repair. And the patch allowed us to position the valve a little supravalvar in the septal area to avoid a heart block. Here is another patient with insufficient tissue for a distortion-free cone repair. So the anterior leaflet, the inferior leaflet, here's the septal leaflet. There's a gap between the septal and the inferior leaflet, causing severe tricuspid regurgitation. Here we start by mobilizing the septal leaflet. See that we dissect the papillary muscle in order to elongate them and to allow the better coaptation distally. Now we are taking down the anterior leaflet together with the inferior leaflet in order to look behind the leaflet and cut the abnormal attachment of those leaflets to the RV. Now we put together the septal with the anterior leaflet. Then the inferior leaflet with the septal leaflet. Then we close a little bit the anteroinferior commissure, placate the annulus, and start reposition the valve in the normal annulus. And we noticed that was missing tissues. We need to get more tissues. And then we use this pericardial patch to enlarge it. So since there's a chance of shrinking, we use it a big one. So it doesn't have to grow also. And this allowed us to put it above the sinus, above the normal junction, avoiding heart block. But it's above the coronary sinus. I mean, distal the coronary sinus. So now my colleague is testing it, see the valve close perfectly with saline test. And we look back, it's still there, so it's not leaking at all. The echocardiogram, 6 months after repair, shows the septal patch in supravalvular position and no tricuspid valve regurgitation or stenosis. Then we have this description of the many positions of the tricuspid valve, the many degrees of rotation of the tricuspid valve inside the right ventricle. And in our experience, in all those cases, it was possible to to do the colon repair, as you see in the right. In some case, the valve is extremely rotated to the inside the RV toward the RVOT. In this first case that Ebstein described, he demonstrated that the patient had like a bad anatomy with extreme rotation and dilation of the outflow tract of the right ventricle. And the patient died when he was 19 years old. Here is a patient from our museum, the pathology, heart museum specimen, of a 14 years old patient, meaning that the patient died at 14. And here's the pulmonary valve, and here is the anterior leaflet, very near the pulmonary valve, and also linear attachment. So the only opening was this one. And the RV outflow tract is dilated, meaning that there's a lot of regurgitation in the tracheal valve. This is just a drawing to imitate nature. So in this paper of the Mayo Clinic, they expressed their concern about the valve that have severe leaflet displacement into the RV apex or those anterior rotated into the RVOT that are generally not suitable for the traditional monocusp repair, which is a little different in the cone. Like, this was my first case where the anatomy was like that. The anterior and inferior leaflet are attached to the RV wall, anterior and inferior. And there's by pulling the valve, you can see there's a little hole. That's the only opening toward the functional right ventricle. And this was very close to the pulmonary valve. So we took down those, mobilized that leaflet, so we end up with a big membrane that we can transform like in a funnel, and then we open the distal part of this, make a cone. And here, this is not running, but this, the result, we have a perfect echocardiogram after the repair and a good function of the right ventricle. This is another type of anatomy in the extreme rotation of the tracheal valve in Ebstein anomaly, where we see a distal continuity of the septal with the anterior leaflet. So at the end, we have a hole, but a bigger hole toward the outflow tract that imitate a true valve. It's a true valve, actually, with leaflet and subvalvular apparatus. So in this case, we can cut those attachment near the pulmonary valve, like you see here, and then we close that hole going toward the outflow tract. And next, we take down the inferior leaflet as well, and then we plan to make the apex of the new valve near the apex of the right ventricle. And then we put some suture in this area and made a fenestration. So we got like a membranous valve that functions very well. This is an echocardiogram in another patient, extreme rotation of the tracheal valve into the RVOT. The four-chamber view shows a small dysplastic septal leaflet displaced inferior leaflet. And here in the next, you see that the severe rotation, it's going too fast, let's go back. Can you make this run, please. Oh. Maybe I can go here. Sorry. I think the thing is not obeying me very well. That's why I'm a little here. Okay. So here you can see that the pulmonary valve. Let's see if so you can see the pulmonary valve and the leaflet opening. I mean the valve opening toward the leaf there. And then you can see severe rotation of the trachea valve and severe regurgitation in multiple areas. Now, we have another situation where you don't have continuity of the distal part of the valve between the septal and anterior leaflet. You have some continuity of the septal with the inferior leaflet. So in this case, we took down the valve, the end connected to the septal leaflet. So we detach the abnormal connection near the pulmonary valve, rotated and connected to the to the septal leaflet. So we continue that suture, and then we position the valve, and here we have the result without any patch. Here we have the echo of that case with minimal tracheal valve regurgitation, and you see in the left that the valve is moving very nicely. So here we compare the pre-op with the post-op echo, showing that severe regurgitation was transformed in minimal regurgitation. Here's another case that you see in the left that the valve is connected, is very rotated toward the pulmonary valve. And then in the middle, you see an angiogram showing that there's very small functional right ventricle, and the tracheal valve is open in this direction. And this was done after the Glenn procedure. Then we did the repair. This is a case that we did in Israel a few years ago, and the patient is doing very well with 1.5 physiology. Now I want to call attention for the common repair after tracheal valve replacement in Ebstein anomaly. We had 3 cases done, one in Brazil, the first one, and 2 of them at the Children's Hospital of Pittsburgh. Here's the patient done in Brazil. You see in the MRI that the prosthesis and some tissue underneath the prosthesis. So that prosthesis was calcified, stenotic, and regurgitant. And then on the right, we have the result, which shows a little moderate regurgitation, and over time became a minimal regurgitation in these patients. Then we have this patient that we did here in Pittsburgh, where we had 2 valve replacement, tracheal valve replacement with mechanical prosthesis. So here you see in the echo, that was a gradient of 15 millimeters in the tracheal valve prosthesis, and one of the leaflet was not mobile. And then we reoperated, we removed that valve, prosthesis that has a lot of thrombus, as you see here. Then we mobilized the viable tracheal valve leaflet and construct immobilize the anterior leaflet, then the inferior leaflet and septal leaflet, and construct the valve which become very competent. Here's the echocardiogram, postoperative, showing a competent tracheal valve. This is the other case that Luciana did, was bioprosthesis in a 5-year-old boy. He had previously a tracheal valve repair, VFD closure, and gland anastomosis. Had a tracheal valve bioprosthesis at 4 years of age, and then the cone repaired 5 years of age. The result was excellent. Because of the time concern, I want to skip it. And then the Silva cone operation after the Stern procedure for Ebstein anomaly that we did here in 2019. So I summarize that in special situation, a good mobility of tracheal valve anterior leaflet seems to favor good postoperative RV function and morphology. Hypopath tracheal valve leaflet may require septal leaflet augmentation. Severe rotation of the tracheal valve into the RVOT is associated with linear attachment of the tracheal valve anterior leaflet and requires special surgical maneuvers. However, it is repairable with the cone technique. Cone repair of tracheal valve prosthesis implant may be viable, encouraging the preservation of most leaflet tissues during the tracheal valve replacement in Ebstein anomaly. I want to finish. Thank you, Luciana, who has been working with me for a long time and making suggestions and creating with me regarding the cone operation and many other operations. And I want to thank my son Pedro in name of my daughters Leticia and Laura, who cope with me during my intense career requirement that kept me far from them for a long time. Thank you very much.
That was fantastic. Thank you so much, Dr. Da Silva. I'm going to ask you to stay here on the stage. We're going to have a short panel discussion. Our panelist for this discussion is Dr. Brian Goldstein, our director of the Cath Lab, Dr. Chris Craig from Memphis, who is the director of the surgical program at La Bonheur Children's Hospital, Dr. Da Silva, Dr. Mario Castro, one of our wonderful surgeons, and Dr. Norm Silverman from Stanford. So please join us on the stage. Thank you. And as we start, I have a question to Dr. Da Silva. So when you're augmenting the septal leaflet, what kind of material do you use to augment the leaflets of the tricuspid valve in Ebstein's patients?
Well, to augment the septal leaflet, some surgeons have suggested to augment also the anterior leaflet. I think usually it's big enough, so if we mobilize well, we don't need to augment the anterior leaflet. But regarding the septal leaflet, if the patient is adult, I prefer to treat the leaflet with growth hormone. But it's always autologous pericardium. And in small patients, in children, I prefer to use a fresh homologous pericardial patch. But by now, we don't know for sure which is the best option. It is something that we have to study. We do in about 10% of our patients, so very soon we're going to have enough patients to study what's the best patch. I don't know for sure. Thank you.
Dr. Craig, do you have a comment on that as well?
No, I agree with Dr. Da Silva. I think autologous pericardium has been what I've used.
Fantastic. A question for Dr. Goldstein. I know we use cardiac catheterization in many of our patients before the cone operation, or in patients with stars before we convert them to a cone operation. Are there any cath biomarkers that will kind of sway you away from doing a biventricular conversion in these patients?
Tarek, thanks for the question. Man, I'm not the right person to answer this question. In some ways, I look at this as a partnership. In this particular partnership, our job is to get high quality, reproducible data that allows our team to make good decisions in terms of biomarkers that facilitate that decision as to what's good and what's not. You know, our impression is seeing a good right ventricle that squeezes well, generates some kind of pressure, and has good pulmonary arteries with pulmonary vasculature, meaning low pulmonary vascular resistance, going to facilitate easy antegrade flow, is all sort of positive in my mind. But ultimately, I would say this is a decision that's not made by our team. Our job is to acquire high quality data set.
Fantastic, thank you. It's kind of like a team decision rather than like, you know, just a cath decision.
Yeah, I mean, like anything in a congenital heart center, it's really a team-based care. So I agree with that statement.
Great, fantastic, thank you. Question for Dr. Silverman. You showed very nicely, Dr. Silverman, that there is sometimes fusion between the septal and the inferior leaflet, almost creating a bicuspid, tricuspid valve. How often do you see that, or how often do you, can you always differentiate between the septal and inferior leaflet, or are they sometimes kind of like become only one structure rather than two structures?
Right, it can be sheet-like. It's impossible to recognize it because there are no commissures to guide you. The only thing you have to guide you are the papillary muscles. And the one example I showed this morning, there were two groups of papillary muscles on the posterior leaflet with a commissure or a clip between the two. So it can be very complicated and very difficult because you don't have landmarks to recognize a commissure.
Mm-hmm. Fantastic, thank you.
We showed anterior and septal, but you can also get septal and posterior leaflet fusion. I'm sure Dr. De Silva can tell you that you've seen more of them than I have just seen on the echocardiograms.
Yeah. Dr. De Silva, and you want to comment on that?
Thanks, it's very significant. You're asking some very important questions, but we don't always know the answer. In this case, sometimes the anterior and septal leaflet, they are in continuity, and you don't know where one finishes and the other starts. But for us, in that situation, to have a lot of linear attachment and to have a single hole going toward the outflow tract of the right ventricle, it's important to take down those attachments so you can mobilize the valve to the center, of the right, to the body of the right ventricle. That is very important. And it's especially difficult to define where's the inferior leaflet and the septal leaflet, the limit between them. And when you have a rotation of severe rotation, more often you don't see the limit there. So I think they are fused and you cannot recognize except for the positioning. Mm-hmm. So you don't have the precise limited, but you know how do you say, both together. You see a single piece, the part is the anterior and part is the inferior. And you have to define the apex. You have to save some connection, distal connection, the apex that you don't touch. So you kind of transfer the apex of the valve to that region.
Fantastic, thank you very much. A question for Dr. Castro. I know, Dr. Castro, you do a lot of the Starnes operation for patients with Ebstein's in some sick newborns. So in a sick newborn, would you rather do put the kid on ECMO first, let them recover a little bit, and then do the Starnes operation? Or would you rather take them to the operating room and do the Starnes right away?
So usually our experience here, only the sick kids that, like for example, the kid we have a circular shunt, that kid we did not go on ECMO right away, we just go to the OR and did the Starnes, and that's the one that Dr. Da Silva later did the stents after the cone. And the other ones, they're coming pretty sick, so basically we stabilize on the ECMO the first few, I mean, they come in the first hours after being born, we've been putting on ECMO, and then the stent procedure is usually, the day after or 2 days when they're more stable on ECMO. So that's basically our scenario. The other ones that, the newborns that, they already discussed that case that, they evaluated and just decided to put a PDA stent, let it grow, and probably later make the decision if we're gonna do something or get the stents before the gland, or maybe just do the gland stents and then the cone when they come for the fontan. But basically that's our motto. If the kid is so sick, we go on ECMO and then the stents, circular shunt, we do the stents. And those are the scenarios we've been having here. Now we have a supply of newborns that is McGee. That's basically our supply for newborns here at Pittsburgh. So we got a few stents, in the last few years. I don't know, Jose, you have any other comment?
No, I think I agree with what you said. I just want to remember that when you have circular shunt, you have to stop the flow in the pulmonary artery, because otherwise you're going to keep having circular shunt. So you do the stent and interrupt the pulmonary artery. And then you have to use a method that you don't destroy the pulmonary valve, if possible. And mostly we can either suture patch inside the pulmonary valve artery, or you can put some tape around the pulmonary artery. That will be easy to remove after when you do the conversion to cone repair.
Dr. Matt Craig, the same question for you. If you have like a sick newborn, would you rather put them on ECMO before you do the neonatal repair, or would you rather take them to the OR and do the neonatal repair?
Well, 25 years ago, I would put them on ECMO and then do the repair. None of those kids survived. So currently, if we have a patient with a severe circular shunt, we would ligate the main pulmonary artery, place pulmonary artery bands to avoid overcirculation, give them a day or two to recover, and then take them to the operating room. And at that point, you have a look at the right ventricle and tricuspid valve. Often they're suitable for a biventricular repair. If not, you do a stance, and if they are, you unligate the main pulmonary artery, ligate the ductus, and do a repair. The advantage of that management strategy is, again, in my experience, the patient with severe circular shunt are really sick. They're in the neonatal intensive care unit. There's people running around trying to put UACs and UVCs in and get inotropes going. And it takes 3 or 4 hours to get the OR set up and get the bypass machine set up. And all of that, you can do a main pulmonary artery ligation and pulmonary artery bands at the bedside in 35, 40 minutes. And that usually changes the lactate from 11 to 4, and then you've got 24, 36 hours to take the patient to the operating room and more definitively palliate them.
That's fantastic. Thank you very much. Yeah, go ahead, Dr. Silva.
I think that the other possibility is to do the deliveries side by side. And then we have done this, we have described this too. In Brazil, we did one. Actually, I didn't do, my colleague there did it. He put the patient side by side and then was following the echo and the blood gases. Everything was going, the tendency to go to worse. Then he opened the chest immediately. So this will take very few minutes because everything was prepared beforehand. So that's another strategy that can be used to resolve the issue of low cardiac output quicker.
That's great. Thank you very much. Now let's say he's a little bit less sick. So the kid is like a newborn, desaturated, and we're trying to decide if we do like a PDA stent or if we do the Starnes operation. So I want to go back to Dr. Goldstein and ask, like, what's the role of putting a PDA stent in some of these quasi-stable Ebstein patients, newborns?
Yep, thanks, Tark. PDA stent is certainly a really nice adjunctive therapy in patients who are desaturated, where circular shunt is not on the table as an issue. It really is establishing a stable source of pulmonary blood flow for an interstage period of time before something next. And so, again, in the team spirit, I think this works out very well as a strategy to leave a virgin chest for that next operation, but establish a stable source of pulmonary blood flow that's reliable, allows the pulmonary artery vasculature to grow, and then move on to what's coming next. But clearly in this scenario of severe tricuspid insufficiency, pulmonary valve incompetence, et cetera, this is not a great strategy. But in the setting of pulmonary atresia, functional pulmonary atresia, where the size of the heart and compression on the airway, et cetera, is not an issue, I do think PDA stents are a really nice 2024 approach to establishing a stable source of pulmonary blood flow and leaving the chest closed.
Fantastic. Thank you very much. Any comments from our surgical panel on that particular question?
So I appreciate all our interventional cardiologists' activities. I have a personal bias against a ductal stent in the context of Ebstein's anomaly, and the reason for that is the ductus is directed directly at the pulmonary valve, and so it limits a marginal right ventricle from ejecting into the pulmonary artery because the flow is directed directly at that pulmonary valve. So my bias would be either to do a biventricular repair and ligate the ductus, or if you don't want to do a repair, do a more peripheral shunt where the flow of the shunt is not directed at the pulmonary valve.
Super interesting for sure. That is where the duct is directed. The first step for us was to make sure that when we do this stent, we don't trash the pulmonary valve. And I think we've been able to do that well. But from a velocity of blood and kinetic energy of blood, it is hitting head on. I would love to see MR data to suggest that that approach actually plays out as a functional difference in terms of antegrade blood flow, because I think hypothetically it's really interesting. An MR probably could give us some sense of whether or not that worked if you had a couple of patients down both pathways. It is a very intriguing thought. Thanks.
Thank you. That is great. I think we have time for one more question to the panel. I'm going to ask this question to Dr. De Silva and Dr. Craig. If you have a stable Ebstein's patient with severe tricuspid regurgitation and gradual dilation of the right ventricle, who's starting to get symptomatic, what would be the best age you would, like if you have to decide the best age to do the tricuspid valve repair or the cone operation, what would be your, your chosen age to do the operation?
3 months. At 3 months of age, you can do a Glenn safely, and the Glenn is God's way of saving the cardiac surgeon from disaster. Because you add a Glenn, you've got cardiac output, and then you can do a quasi-good repair.
Yes, I think the patient that is stable and the patient has cyanosis, then I agree that we have to do early. I don't know if it's 3 months or 6 months, but it has to be early on because the cyanosis is not good in the long term, can deteriorate the ventricle, and also the patient, is not well oxygenated, not very good. And after 3 months to 6 months, we can do the operation with good result, and that could be the reason. But if the patient is not cyanotic, then we can wait a little more. It's not severely cyanotic, it can be cyanotic, like with the 80 or 85 or so, or 90, then we can wait a little more and do around a year of age, a little before or a little. This has been our preference, but we need to have more studies to see what was the best. But I strongly agree that you do have to do early on if you have cyanosis, especially severe cyanosis.
That is fantastic. Dr. Narcraig, you have a
One
comment?
last comment. So I've had 3 referrals from Oregon, all 3 of them from Oregon. And these were kids that were neonates, severely symptomatic, and somehow staggered off ventilation. And the cardiologists would call and say, the patients are fine, I think we can wait. And the symptoms of the patients, all 3 of those patients died, and they died of aspiration. The diagnosis was aspiration. I think severe right heart failure in the neonate and the early infant manifests itself in feeding intolerance, and that's the genesis. You'll hear all 3 of these cases, the patient died of sepsis secondary to aspiration, and I think what they died of was right heart failure without an adequate intervention, surgical intervention.
That's fantastic. That speaks to the role of trying to do early referral, especially when there is excellent surgical experience. That is wonderful. So thank you guys so much for this wonderful discussion. Please give our speakers a round of applause. Thank you very much. Our next session is a very exciting session as well. It will be talking about the patient experience after the cone operation for the tricuspid valve. I want to introduce our Erin Colvin, who is an advanced nurse practitioner at the Ebstein Center, at the Silva Ebstein Center. She is also the director of our advanced practitioner team at the Heart Institute. She is the person behind the scene for all the great work that our team does. And she's a wonderful patient advocate. So welcome, Erin.
Hi, everybody. I have the pleasure today of introducing this video that you guys are going to watch. And this is a video of one of our success stories. I had the pleasure of meeting Jessica when she reached out to us for a semi-urgent second opinion. She was very surprised to learn what we could offer here at the De Silva Center. So please enjoy her video. She does a great job of explaining her journey with Ebstein's Anomaly. Thank you.
Hello, my name is Jessica Shackelford, and I would like to share about my journey with Ebstein's Anomaly and to the De Silva Center. I was born in 1975, and my first open heart surgery was when I was 5 days old to put a ring around my tricuspid valve, which was to hold it open. My second surgery was when I was 3 years old to repair my ASD, which is a hole between the upper chambers of the heart, and that was when I was diagnosed with Ebstein's Anomaly. My childhood was pretty normal. I went to school, I played sports. I had a heart cath when I was 8 years old and another heart cath when I was 13 years old. I started having bouts of arrhythmias when I hit my teenage years and was cardioverted one time, which didn't work, and I had to go on to some medications. In my 20s, I continued to have issues with arrhythmias, and medications were not working. So they recommended that I have a valve replacement, and I was given the choice between a tissue or a mechanical, and my third open heart surgery was in 1999, and I received my first mechanical heart valve. It was at St. Jude's, and it lasted for about 10 years. During those 10 years, I had bouts of arrhythmias again. I broke through many medications, so I was looking at a possible ablation. Prior to my ablation, I had a TEE, which showed a clot in the leaflet of my mechanical valve and was holding one side closed. Instead of the ablation, I went for an emergent surgery and had another mechanical valve put in. This time it was an O-onyx. For the next 12 years, I was doing pretty good, other than I had issues with arrhythmias. In 2022, I noticed I had started having some symptoms of not being able to go up hills and walk for very long distances like I have in the past. I made an appointment in June of 2022 with my adult congenital heart doctor. I had an echocardiogram which showed that a possible clot on my mechanical tricuspid valve. Again, Dr. K mentioned that my native tricuspid valve was visible, and maybe I should consider a cone procedure if there is indeed a clot on my mechanical valve. We have to do a TE to confirm. I had no idea what a cone procedure was. I even asked whether my native valve was truly there because I was told that it was removed in my previous surgery, number 4. He said it absolutely is there, and he was going to talk to a surgeon that he knew about possible cone procedure. So when I went home, I researched because I've never heard of it before. In all of my 47 years at that time, I never heard of the cone procedure. To my surprise, there was quite a bit of information out there. And I came across a video that Dr. De Silva did about the procedure and the website for the De Silva Center. I learned that the procedure was innovated by Dr. De Silva in 1993 and that he practiced at the De Silva Ebstein's Anomaly Center in Pittsburgh, Pennsylvania. So of course it opened up another window and I immediately looked up to see the distance between my home and the De Silva Center. And I got excited because it was only 3.5 hours for me. And I thought if I have to have another open heart surgery, my 5th one, that I might as well go to the man who innovated the procedure. I was able to send a message through the website asking for a consultation. And I was quite surprised that they offer free consultations, which I think is just phenomenal. This is an excellent offer. And I heard back from Aaron within about a day or two. And in July 2022, I had my TE, which confirmed that I did have clots on my onic mechanical valve holding the leaflets closed. So my records continued to be sent to Pittsburgh, and my surgery was scheduled for July 2022. My treatment and experience with Dr. De Silva Center has been phenomenal. From the time that I got my records to the time that I got my surgery scheduled and completed, it was about 2.5 weeks, so it was pretty quick. I was going into it not knowing whether I was going to have another mechanical valve or actually get a cone. Since my native valve was 47 years old, there was no guarantee that it could be done until they could get in to see what my native tissue was like, the condition of it, and how much was left to see even if a cone could be done. My husband told me that after the surgery, when De Silva came out to speak with him, he said he was kind of bouncing towards him because he was excited as well that he was able to do a cone. So I'm going to try not to tear up, but I have a cone and I no longer have a mechanical valve. I am grateful for De Silva and his team. They are phenomenal. Dr. De Silva and his wife are magicians. The care that I received at Children's Hospital in Pittsburgh was outstanding. Everyone was very supportive before, during, and after my surgery. I feel I actually recovered better and sort of faster than the ones I've had due to the care that I received. The follow-up has been fantastic. Anytime that I reached out, I got a response and they answered all my questions. One fun fact, I am the first person in the United States to have a mechanical valve removed, and a cone placed. I was able to get a cone in my tricuspid, and I am forever grateful to Dr. De Silva, his wife, Erin, the nurse practitioner. She's just wonderful to work with, the surgical team, and all of the nurses at CHP. My journey to Dr. De Silva Center has been a blessing, and I am extremely blessed that I have found the clinic and Dr. De Silva and his team. Thank you.
That is so wonderful, so moving, and thank you. We're going to wrap up a little bit with the last presentation, I'm going to be sharing with you some of the results of our center for the COM procedure. I'll have to apologize in advance. We're still gathering a lot of data, so this is not very complete in terms of extent of the data that I'll be showing you. But just to give you a little bit of a glimpse of how we're doing in terms of the numbers so far. My disclosures here are not particularly pertinent to this presentation. So just to give you a bit of background, and you already have heard some of this, but this was the COM procedure was first applied in 1993 in Brazil by Dr. Da Silva. And then this truly over the years has proven to be the only true repair. You can, next, okay. Since 2005, when he first presented at the ATS the video showing the rest of the world how to do this, and this really became embraced by the surgical community gradually. And after all this extensive experience that he had had in Brazil, and through which he actually taught many people all over the world, and in collaboration with other experts that we heard earlier today, we then were able to recruit Dr. Silva in 2016 to Pittsburgh, and Dr. Mora created the Silva Anomaly Center. So we've had our own experience here in Pittsburgh, some of which you already heard. It's that the battery is not going so well. Okay. So since then, the Silvas have performed here in Pittsburgh 110 procedures. So I'm going to cover a little bit of the postoperative complications that we've seen, the mortality, some of the adverse effects, and just very little on the valve function. Just to tell you about the population that we've seen in Pittsburgh, you can see that there is a small number of infants. There were 9 infants in this time period. Most of the patients that we've served are children, there's almost 30% actually were adults, as you heard the moving story earlier today. So this really reflects the diverse age presentation of this disease, and truly how when you're dealing with this condition, you have to be ready to tackle from the fetus to the adult with congenital heart disease. A significant number of these patients had prior surgeries of some kind. As you can see, 38% had tricuspid valve repair or cone performed previously at other institutions. We had 8 stars, as you heard now that number has gone up. Isolated BT shunts or PDA stents were present in 10% of the patients. Some patients had bidirectional Glenn, and as you saw an example earlier, there were 2 patients that had a prior tricuspid valve prosthesis that underwent cone after tricuspid valve prosthesis. Most of these patients were symptomatic, although you heard before also how difficult it can be sometimes assessing symptoms, and that often you do need exercise data or other parameters that actually demonstrate limitations. And some patients were very, very sick, as you can see, 5.8% extremis in ECMO. Preoperative conduction abnormalities were quite common in over half of those patients, but about 7% of them had WPW. Of all these patients that came for a COM procedure, all of them had a COM procedure, and there were no initial tricuspid valve replacements. This is the median cardiopulmonary bypass time and the cross-clamp time. And it's very common that at the time of the cone, these patients have additional concomitant procedures, which may be a partial or complete closure of the atrial septal defect, CTI ablation or MACE procedure, sometimes pulmonary valve or after tract procedures like reconstructing the pulmonary valve, or pre-existing takedown of very surgical shunts. Obviously, that may be necessary. You can see that with the growth of our program, we have had a significant increase in the number of patients referred for these procedures over the last few years. And these patients have come from all over the world. You can see that it has become one of the most common resources for referrals, outside referrals to our program, is Ebstein's anomaly, which is incredible considering the rarity of the condition. When you look at the distribution in age groups, as a little bit was said before, but also shows you how infants are rare, but they still happen. So every year we have a few infants that give us trouble, give us headaches, because those are the most challenging. And obviously we're all learning on how to manage them, and there were very nice discussions on that early on. A little bit on the early postoperative events. This gives you the mean length of stay was 8 days. The ICU stay was 3 days, so very reasonable. Need for reoperation early, tricuspid valve repair in one patient. One patient needed a shunt because of decreased pulmonary blood flow, and one patient needed a Glenn. Temporary ECMO was used in 4 patients, and there were 4 patients that needed a pacemaker. Some of the late events that we have collected so far, and obviously so important as most of the bigger numbers we've had in the last couple of years, we really look forward to seeing this data over time. But we have had tricuspid valve reintervention in 4 patients, 3 of whom had a redo. So this is 2.7%, so redo of a cone. There was 1 patient that required a tricuspid valve replacement, an adult patient. 1 patient who had presented late and had severe ventricular dysfunction, an adult patient, ended up referred for transplant evaluation and ended up having a transplantation. There were 2 patients that needed a Glenn or a Starnes, 1 each, and 1 patient ended up having a Glenn takedown. 1 patient required a pulmonary valve replacement. And there were 2 non-cardiac deaths, so essentially no mortality during this follow-up, which are recognized as relatively short for the most recent patients. But there was 1 patient who had a brain tumor, a glioma, and died after that, after having had neurological surgery, and another patient who died who had a tracheostomy, who died from a respiratory complication related to a tracheostomy that had nothing to do with the heart, really. So probably if you do a statistical analysis, we may find that brain tumor is a predictor for death after the cone. In any case, when we look at the tricuspid valve regurgitation, you can see that the vast majority of patients, over 80%, had a moderate or severe degree of tricuspid valve regurgitation. And in the last echocardiogram, that shifted significantly towards the trivial or mild, with much less residual insufficiency after repair. We are gathering a lot of these data now, so we're hopeful that in the next year or 2, we could especially present to you MRI data and echo data, and hopefully some exercise data in the older patients that can help us understand, the timing of this condition, of this surgery, what are the best times to do it, and the implications. As has been presented before, this is especially in infants and neonates, the mortality is quite high all over the world. This is data from STS, and this was shown previously too by Dr. Arnold Craig. So it's really, I think we're very proud of the incredible team with the Silvas here and the ICU care and the multidisciplinary efforts to take care of these patients and have such good results, especially when incredibly pretty much absent mortality in this group. So just briefly then, just to conclude, we can say that of these 110 patients that included very diverse complex populations, including patients who had had Starnes, patients who had had prior cones in other institutions, prior failed tricuspid valve replacements. These patients all were able to offer a cone repair with remarkable outcomes, with no mortalities and relatively minimal morbidities. So this is really life-changing for these families. It's clearly showing a durable longitudinally function, and also really enhances how much we really need to study these patients I'm hopeful that we can put together an international registry for Ebstein's anomaly so that we can really gather information, especially about the timing of intervention. Now that we have such a wonderful surgical technique, should this be done much earlier before we're seeing all the late effects of right ventricular dysfunction, arrhythmias, etc., to really improve outcomes, quality of life, and impact this patient population further with benefits. So I think this is a challenge for all of us, and hopefully we can be proactive about gathering that information and getting our patients involved in prospective ongoing surveillance. Thank you for your attention. I'm just going to say that this has been wonderful today. I don't know if there are any questions for me. I know there wasn't any particular panel after this, and we had a chance to talk a lot. There's my email, and I can also we can also connect through the online for any questions that may come up. I wanted to thank everybody as we're wrapping up, and especially, this has been an incredible journey, as you have seen some of the pictures that you saw before. I want to thank especially for this symposium today, all the faculty and all their wonderful presentations, especially our invited guests, Dr. Noel Craig, Dr. Simone Pedra, and Dr. Norm Silverman, of course, for incredible contributions. And I wanted to thank the organizers, especially Katie Scollon and Drew Berghardt, for all the work to put all the details together, our patients that have contributed, and we couldn't do any of these without Jim Ferris with Massive Media for all the audiovisual. He's done always does an amazing job. It's the supporting work from HVI and from Children's Hospital Pittsburgh to allow us to do all this, present this here today. And of course, the course directors, and especially Dr. Jose Pedro da Silva and Luciana da Fonseca da Silva and Dr. Morel for putting together this symposium. This has been really wonderful, and we hope to keep doing this every year and give you some more further updates as we learn more about this very, very challenging condition. Wanted to make a little announcement about the patient-parent conference. That's something we're going to push for next time. We're going to try to gather a larger group of parents, and there will be an announcement for a future event in the spring, especially dedicated for parents and patients. So for those parents and patients that may have logged on, we will have more to come, okay? Thank you very much.